just in a second we will be live. Just yeah.
1 second. Yeah.
Yes, it's in a process.
Good evening.
Good evening, doctor.
Just in a second.
Dr. Jaiswal, namaste.
हाँ
कैसी हो
नमस्कार
आप?
मैडम कैसी है
Nice to see you. Nice to see you.
हमको भी you're really nice. You're so all the time you're having a smiling face. Nice to see you.
Yeah.
Actually, I
Abhi,
just
let's
started.
start.
अरे भाई मैं सबको बताऊं मैं नानी बन गई दोबारा.
अरे वाह बधाई हो
छोटी
बहुत
बेटी के भी अब बच्चा हो गया.
Congratulations, madam.
Great congratulations.
Congratulations, ma'am.
Excuse
start the recording
excuse
now.
me and good evening, respected faculties. We are live now on YouTube as well as on Core Connect.
Thank you, Abhishek, for starting the meeting. I am Dr. Monica Umbardan. I am the coordinator for Public Awareness Committee, Fogsi. I welcome you to the 8th episode of the zonal webinars which the Public Awareness Committee conducts. This is with the North Zone committees on cervical cancer. This is the last in the series with the respective zones. I request Dr. Alka Pandey, madam, to welcome all the faculties and delegates as the Vice President in charge of this committee.
Hello, good evening, everyone. And on behalf of Dr. Priyankur, I welcome each and everyone, and especially Dr. Alka Kriplani, madam, who has been our President Foxy, and Anita, Monica, Shatabdi. Yes, Anita Sabarwal. Yes. So I will, Dr. S.P. Jaiswal, ma'am.
Namaskar, madam.
A very warm welcome to all of you. And now I request the chief guest to bless the webinar.
Abhishek,
Very good afternoon, everybody. Dr. Mika, who
Ma'am, that's what I was saying. Let us at least inaugurate the webinar and let me formally introduce you. Then you can give your remarks, ma'am.
कोई बात नहीं.
Thank you, ma'am.
घर के लोग हैं, सब घर के लोग हैं.
Can we have the inauguration, please? Before we start any event, we take the blessings of God Almighty. Let God bless us with all His power and wisdom, so that we. Abhishek, the voice is not very clear. That's okay. Let it be. Yes. Can I have Dr. Alka ma'am's slide, please?
Yes, ma'am.
Shatabdi?
Yes.
Yeah. Can you introduce ma'am formally?
Yes. A very good evening to everyone on behalf of the Public Awareness Committee. As Monica said and Alka ma'am said, that today is our 8th episode of the series of zonal webinars that we have been doing. Abhishek, can I have the slide, please? Alka ma'am?
Yes, ma'am. Just a minute.
Yeah, our chief guest for the day is Dr. Alka Kriplani ma'am and Dr. Archana Verma ma'am.
The next slide,
It's my
please.
immense pleasure.
This is not the slide.
It's my
Yes. Sorry, ma'am.
Yeah.
कोई बात नहीं, दोनों अलका है ना.
It's my immense pleasure to welcome Dr. Alka Kriplani ma'am. Dr. Alka Kriplani ma'am is a director and head Department of Gynecology and Obstetrics and ART at Paras Hospitals, Gurugram, and ex-professor and head of department at the All India Institute of Medical Sciences, New Delhi. Madam has been the president of Foxy. Madam has been the president of GESI, TGES, AOGD, you name it, and she has been the president of the association. She has won a total of 47 awards, including the Padma Shri Award for Distinguished Service in Medicine by the President of India in 2015. A very warm welcome to you, ma'am. We would like to have a few words of blessings from you.
First of all, thank you for such a lovely and short and crisp introduction. Where shall I start with Dr. Monica? I think she has worked maximum because I got so many phone calls and from her. So Dr. Alka Pandey, whom I know for decades, she's such a quiet, humble and such a sincere worker. Then I could see Dr. Jaiswar always smiling. Anita Sabarwal, who is the queen of, Delhi academic activities. And I think Priyankur is also involved with this. And I congratulate you all for this 8th webinar of the series. How much you people are working hard. So hearty congratulations to Public Awareness Committee. And it is such an important topic of, to go to public preventing cancer. So see, these vaccines have improved longevity like anything. People were dying from smallpox and from tuberculosis and things, and vaccines have changed the scenario so that now the main killer is cancer. And if cancer can be prevented by a vaccine, that is really, it looks a far-fetched dream, and it is possible in our field. And I think 99% of cancers can be prevented. But the one disheartening thing is still the awareness. You people are working so hard. Still the awareness at the ground level, so much more is desired. So many of us have to take this agenda forward and tell all these young girls, those who have insurances, they come in 40s and 50s. I think it is wasting. It is the young girls we should catch before they start sexual activity. And we really have to work hard. Don't leave any chance, any patient coming with her daughter, tell her to get vaccinated. And let us see my dear friend Nirja Bhatla. I think it was the very initial when once I told Nirja, you think this HPV vaccine will be, useful? From those days, Nirja is working on the vaccine and she has come a long way. She has taken preventive oncology to her heart and worked so well. By her lecture, you will realize how deep knowledge Nirja Bhatla has got on this subject. And what to say, Niranjan? Niranjan is speaking on management. So I think you will really be updated about prevention and management of cancer cervix today. Without wasting time, I wish you all the best. Again, hearty congratulations for the 8th webinar and doing such wonderful work. Public Awareness Committee is doing great work. And this is a very apt topic that cancer vaccination should be the top priority of Public Awareness Committee. So I wish you all the best, and I will also be listening to your lectures. Thank you.
Thank you so much, ma'am. Thank you for this lovely words. I would now want to welcome Monica to please introduce Dr. Archana ma'am if she is joined. Monica?
1 second. I can't see Archana ma'am actually.
Then I think we'll proceed with the talk then. We can take her words when she joins.
The problem is Nirja ma'am is in a meeting. She will take another 5 minutes.
Can you start with the panel?
Ma'am, I will just check with all the panelists. You can start with a panel if you want, ma'am, because Nirja madam will come back after the meeting. So she said another 5-10 minutes, ma'am. And Niranjan sir is not picking up the phone, ma'am. So what exactly you want me to do, ma'am? Can we start with a panel if you want?
Yeah.
I think we can go ahead with that. Yeah.
Okay. We can start with Alka madam's panel first.
Yes.
Abhishek?
Yes, ma'am. I'm sharing. Just
Yeah. Shadabdi, can you introduce the panelists in the meantime and the moderators in this?
Yes, of course. We'll start with our panel discussion. Our panel discussion today is on screening methods, management and vaccination of cancer cervix. Our moderators for the panel are Dr. Alka Pandey ma'am and Dr. Nisha ma'am, and our expert is Dr. Mamta Dagar ma'am. Abhishek. Dr. Alka Pandey ma'am, as we all know, is the vice president of Fogsi for the current running year. She is an associate professor in the department in Patna Medical College. Patna.
Okay,
yes, welcome, ma'am. Welcome, ma'am.
Yeah.
Yes, ma'am. The next panelist is Dr. Nisha, ma'am. Dr. Nisha, ma'am, is the unit head and in charge in genital cancer control unit at King George Medical University, Lucknow, and also the vice president of the Association of Gynae Oncologists of India and Lucknow Obstetrics and Gynecology Society. She has been awarded with Asia's Top 50 Academician Award in the year 2021 and also with the Sushen Chikitsa Seva Gaurav Samman in 2019. Welcome, Nisha, ma'am. Our expert panelist today is Dr. Mamta Dagar ma'am. Abhishek, CV please.
It is already on the screen, ma'am.
Okay. I am not able to see. Monica, yeah. Dr. Mamta Dagar ma'am is a certified robotic surgery training. She's had a certified robotic surgery training from Paris. She's a diploma in gynae endoscopy from Kiel, Germany. She's a senior consultant and professor at Gripmer Institute of Obstetrics and Gynecology, and also at Sir Gangaram Hospital in New Delhi. And her special areas of interest are preventive oncology, endoscopy, and robotic surgery, and high-risk pregnancy. Welcome, Mamta ma'am. We have a good elaborate panel today. We have Dr. Meenakshi Mehta ma'am, Dr. Nighat, Dr. Kiran Chandana, Dr. Sonal Agarwal, Dr. Gini Gupta, Dr. Gayatri, Dr. Aradhana, Dr. Jayashree Sundar ma'am, Dr. Amber Khan ma'am, and Dr. V. Aishwarya ma'am. Can we have the CVs quickly, please? Abhishek?
Yes, ma'am, it's on the screen.
Why can't I see it? Monica, will you proceed if you can? Dr. Meenakshi Mehta is a consultant at Nova IVF Hisar. She's had her fellowship in ART from Nadkani Medical Training Academy, and she's graduated from the BD Sharma Medical College, Rohtak, and she's had almost 11 years of experience in the field, and she's published 2 international papers and case reports in international journals. Welcome, Dr. Meenakshi. Our next panelist is Dr. Nighat Firdos ma'am. She is a professor and former head at OBG GMC SGR and the past secretary of Srinagar Obs-Gynae Society. She has had a teaching experience of 40 years and she is a counselor at IGNO. Welcome, Nighat ma'am.
Thank you. Thank you.
Our next panelist is Dr. Kiran Chandana ma'am. Ma'am is the president of Faridabad Obs and Gynae Society and also member of the MTP committee of Fogsi. She has a special interest in adolescent health and contraception and an active member at Fogsi and at the Faridabad Obs Gynae Society. She's contributed multiple articles in various journals. Welcome, Kiran ma'am. Our next panelist is Dr. Sonal ma'am. She's a senior consultant at GR Hospital, Kosi Kalyan. She's a live member of Foxy, UPCOG and IMA. She's the current secretary of the Mathura Obs-Gynae Society. And she has special interest in water birth, labor analgesia, lap gynae and high-risk pregnancy. Welcome, Sonal ma'am. Our next panelist is Dr. Gini Gupta. She is a chief consultant at Healthline Hospital, Ludhiana, and the General Secretary of Ludhiana Obs-Gynae Society. She is the Manyata champion and coordinator for Punjab, and she has been the faculty at various state and national conferences. Welcome, Dr. Gini. Our next panelist is Dr. Gayatri Singh. She is the secretary of Bareilly Obs-Gynae Society. She's been practicing for 30 years and she's presented papers in various Yuva Foxy. Welcome, Dr. Gayatri, ma'am.
Thank you.
Our next panelist is Dr. Aradhana Singh. Ma'am is the president of the Noida Obs and Gynae Society and also the additional director at Fortis Hospital, Noida in the Obs Gynae department. She has been the organizing secretary of North Zone Yuva Foxy and also the secretary of the Noida Obs Gynae Society between 2013 and 2015. Welcome, Aradhana ma'am. Our next panelist is very dear Dr. Jayashree Sundar ma'am. Ma'am is the director at Madhukar Rainbow Hospital, New Delhi, and her special areas of interest is obstetrics, both low and high risk pregnancy, preventive gynecology and adolescent health. And she's conducted various academic activities, including the recently concluded the first PAC conference that we did in Delhi. Ma'am was one of the organizing persons. Welcome, Jayashree ma'am. Our next panelist is Dr. Amber Khan ma'am. She is a consultant at GHK Hospital, Jaunpur. She's currently the secretary of the Jaunpur OBGY Society. Her areas of interest are high-risk obstetrics, USG, infertility, colposcopy. and she's participated and given talks in various conferences. Welcome, Dr. Amber ma'am. And last but not the least, our final panelist is Dr. V. Aishwarya. She's worked as an assistant professor at Stanley Medical College for 2 years, and currently she is the consultant at Healers Hospital, Bijnor. Welcome, Dr. Aishwarya ma'am. I now hand over the stage to Alka ma'am to please conduct your panel, ma'am.
Thank you.
Abhishek, please start sharing the slides.
Yes.
Which Madam,
Yes, ma'am. Ma'am, hope it is visible.
थोड़ा सा बड़ा कर सकते हैं क्या?
Ma'am, it's a full screen only. Sorry.
Okay. Then my co-moderator, I welcome everyone to this conservative surgical management of carcinoma cervix panel. And my co-moderator is Dr. Nisha Singh from Lucknow. Welcome, Nisha. And the panelists are, next slide, please. Dr. Meenakshi Mehta, Dr. Nighat Firdaus, Dr. Kiran Chandana, Dr. Sonal, Dr. Ginny Gupta, Dr. Gayatri, Dr. Aradhana, Dr. Jayashree Sundar, Dr. Amber, and Dr. V. Aishwarya. Next slide, please. So please take up the questions one by one. So it is carcinoma cervix is the second most common cancer in women worldwide. The global incidence is about 5 lakh new cases per year, and in India it is 1,25,000 new cases per year. Next slide. So the primary screening methods for this deadly disease that we have are Pap smear, HPV DNA, HPV plus Pap, co-testing, and VIA and VILI. Next. So now we come to a case. Mrs. X, 35 years, gravida 2, complaining of white discharge, PV. PA, PS, and PV examination shows nothing relevant, but Pap smear shows high grade SIL. How will you manage, and how are you going to manage? Anyone? This question is to my panelists. Anyone can take up this question.
Hello, ma'am. High grade squamous intraepithelial lesion.
HSIL.
HS, yeah, high grade.
Yeah.
High grade squamous intraepithelial lesion should be directed to colposcopy.
Yes.
And
very good. Yes.
And ECS should also be done if the lesion is extending up to beyond the SCJ. Then ECS should be taken.
Yes, next slide, please. Next slide. So how will you triage? Yes, you said very well. You will do a colposcopy. Next slide, please. So according to WHO guidelines, screening and treatment approaches will be screen and treat approach. In the screen, triage, and treat approach, the decision to treat is based on a positive primary screening test, followed by a positive second test, that is triage test, with or without histologically confirmed diagnosis. Next slide. So what you said was that cytology as the primary screening test, followed by colposcopy triage, followed by, if required, treatment. Next slide, please. So what investigations, what else would you like to do in this case? Would you like to go for ultrasound or MRI or CT scan?
Yeah, basic ultrasound is must in this case. Well, very nicely done TBS is must
Yes.
in this case. And in, if possible, then VIA could also be done.
Hello.
VIE तो पहले ही करते हैं.
पहले ही
पहले ही
करें,
करते हैं.
हाँ जी,
Hello. Hello.
Yes. Yes. Next slide. So colposcopy, ultrasound, and CT MRI can be done. Next slide, please. So what is the role of colposcopy in screen positive cases? Suppose something, it has come screen positive. So
Ma'am,
what will colposcopy tell you?
ma'am, colposcopy, can I take this question?
Yes, yes.
Ma'am, colposcopy will help in confirming the diagnosis of the screen positive test. Moreover, with colposcopy, we can also see the extent of the lesion. Also can help in taking the biopsy of that particular lesion in the
Yes.
screen test.
Colposcopically directed biopsy is very good. Okay, next case, please. Next slide. So to confirm the screening test, to locate, evaluate the extent of the lesion, and to direct the diagnostic biopsy, as she has said. Very good. So next slide. Next slide. Next slide, please. So what are the treatment options? Anyone can take this question. What are the treatment options for CIN? CIN 2 or 3?
Ma'am, Dr. Jayashree here. Can I answer?
Yeah, yes.
Yeah, so ideally, as we rightly said, it should be a see and treat policy. So when we see on colposcopy and we're able to see an adequate colposcopy and we're able to see the extent of the lesion, we can do cryotherapy in this patient. If cryotherapy is not possible and not done, large loop and a loop excision biopsy should be done. So it should be, if we are able to see the margin of the lesion, it should be a leap therapy or a cryotherapy should be done.
Yes, very good.
And the
Next
patient should
slide.
be kept on follow-up.
So you can do a cryotherapy for the treatment, electrocautery, vaporization, leap, and conization. Next slide. So, doctor, how do you do cryotherapy? What are the advantages, disadvantages, and complications of cryotherapy? Please, anyone can take up this question. Jayashree, ma'am.
Ma'am, if we have to, so let me answer. The cryotherapy, ma'am, we do it in the, it's a very inbuilt machine whenever we do it. It is like you cool and then recool. So it can be done as an OPD procedure or when we are doing a colposcopy. So we follow the protocol as per how it is done, 1, 3, and 3. I'm not exactly able to say, but then, but you should not pull or push on the cryo machine. That is very important. But the advantage, it is very, it is a very simple procedure. It can be taught to even the basic staff also. You don't need a doctor also to do the procedure. The disadvantages are that the machine handling has to be adequate, and also the patient should be counseled that she might have a lot of discharge for up to 6 weeks. That is one thing patients are very worried about, that they can have a lot of discharge. Complications in cryotherapy are not as much, but complications might include, if you don't use the machine correctly, you can burn, or you can freeze the other parts of the tissues. But it is very advantageous, mainly because it can be done easily and it can be taught to many people. So cryotherapy has its advantage. Disadvantage, the main is we should tell them about the watery discharge, because patients are very annoyed.
Yes.
And is very important once we do the cryotherapy.
Yes, very good. Next slide, please. So here we freeze the tissues. First, we have to freeze, thaw, freeze technique. Next slide, please. Next slide. So this is the cryotherapy equipment. Liquid nitrogen is there. Cervix looks like this. after cryotherapy, immediately after cryotherapy. Next slide, please. So next slide. So the main disadvantage of cryotherapy is that you don't have any tissue sample. So you miss out on diagnosis of early invasion, and it is not appropriate for large lesions and endocervical canal lesions. Next slide. And the complication, as madam said, that is increased watery discharge from vagina. Sometimes severe bleeding may occur, then PID, and there may be no complication at all. So next slide, please. So this can also be treated by laser therapy. Next slide. Now, what is thermal ablation? Nighat, madam? Chandana, madam? Anyone?
Good evening, ma'am.
Good evening.
Ma'am, in thermal ablation, ma'am, I am Dr. Amber.
Yes. Okay.
Yeah, ma'am, in thermal ablation, it is on the principle of heating the intracellular water of the cells, and it will lead to the destruction of the cell around the transformation zone. And we take the temperature up to 100 to 120, and it is applied for 30 to 40 seconds, and we can do multiple applications if we have a large lesion. And it is as effective as cryotherapy.
Yes, yes, very good. Next slide. So, it boils the intracellular water, destroys normal and abnormal cells of the transformation zone, but multiple applications we can do. Temperature is less than electrocautery, and it is as effective as cryotherapy in treating all CIL lesions, and battery-driven portable devices are available. Next slide. So in a low resource setting, colposcopy plus VIA plus biopsy plus thermal ablation is done as a screen and treat procedure. Next slide, please. So do you think loop electrosurgical excision procedure is beneficial in these cases? And what are the advantages and disadvantages of this loop electrosurgical excision procedure?
Can I take this question?
Yes, yes.
I'm Dr. Sonal. The loop excision, electrosurgical excision is a procedure in which a small loop thin electric wire is taken to remove the abnormal area of the cervix. The major advantage of this is we have the tissue, like unlike cryotherapy, we have a tissue here for histopathological examination, and we can even see the tissue which are being missed in the colposcopy. So that can be seen in the histopathological examination. However, it has got few disadvantages, like it can lead to severe bleeding, it requires equipment, can even burn cervix, can also lead to cervical stenosis and cervical incompetence in few patients.
Yes, very good. So next slide, please. So LEAP or LES utilizes a thin electric wire in the form of a loop to remove the abnormal area of the cervix. Next slide. And this is how we do it. Next slide. So you get sample for histopathological examination, and it is indicated for diagnosis of microinvasion, CIN 1 beyond 3 years, then HSIL, no visible lesion on colposcopy, type 3 transformation zone adenocarcinoma in situ. Next slide, please. Now, the disadvantages are again vaginal burns, severe bleeding, sophisticated equipment requirement. Next slide. And long-term complications are infertility due to cervical stenosis, deficient cervical mucus, and cervical incompetence. Next slide, please. So can you throw some light on LEAP and conization? Dr. Kiran Chandana, can you show throw some light on LEAP and conization? Dr. Nighat or anyone can take this question. What is LEAP and how do you do conization?
By conization, we can take more tissue and even CA1A stage also. Wherever when the patient wants fertility in future, so conization is better option and bleeding is less in conization. Less in LEAP, sorry. Conization में bleeding ज़्यादा होती है. And incompetence is more in conization.
Yes. But you take out the tissue in totality.
More tissue can be taken, yeah.
Yes. Next slide. So this is called knife conization, and using scalpel removing a cone, fully visible CIN lesion of any grade occupying 75% of the transformation zone, a CIN lesion of any size extending into the endocervical canal, CIN lesion associated with unsatisfactory colposcopy, adenocarcinoma in situ, microinvasive cancer, where LES and LEAP are not available. Then next slide. So the advantages and difficulties are that entire transformation zone can be seen, taken out, the disease epithelium is taken out, and there is adequate lesion-free margin. Margins are free of thermal damage, and the specimen is of single piece, and but you require anesthesia, skill, there is bleeding, and the patient has to be hospitalized. Next slide, please. So, which is more effective, cryotherapy or LEAP?
LEAP is more effective.
Acha. And what are the side effects? See, in cryotherapy, we have no tissue. That is the biggest disadvantage. LEAP is definitely better than cryo. Next slide, please. So now this is case 2. This is A, 35 years, nulliparous, visited gynae clinic complaining of irregular bleeding PV. Cervix is unhealthy, pap smear shows malignant cells. So colposcopy and LEAP was done. She goes stage 1A cancer cervix, and she wants to preserve her fertility. So is it possible? Is it possible?
Yes.
Next slide.
Yeah.
Yes, ma'am.
Yes.
So how do you classify? The first stage only we want you to classify. Stage 1 carcinoma.
Stage 1 is microinvasive carcinoma. So diagnosis is only by microscopic examination. In 1A, the carcinoma.
Yes.
Ma'am, in 1A, the carcinoma is confined to cervix only. It is further divided into A1 and A2. In A1, the maximum depth of invasion is less than 3, and in A2, it is more than 3 to less than or equal to 5 mm in depth.
Yes. This is microinvasive. Next slide. So what are the fertility sparing? How do you go for a fertility preserving surgery?
I mean, 1A1 up to stage A1, we can do fertility sparing surgeries, like we can go for conization. If there is no lymph vascular space invasion or lymph nodes are not involved, so we can only do that, and we can follow patient further. And but in A2, after A2, we have to remove the lymph nodes as well. And if the margins are found to be positive, then we can go for radical
trachelectomy.
Yes.
Yes. Yes.
Yes, ma'am. Then if patient does not want to preserve her fertility, then we can, in for A1, we can do a simple hysterectomy also. And
No,
in
she wants a conservative surgery. That is what we were talking.
No, ma'am, we can do conization.
Yes. And if the lymph vascular space is involved, then you have to go in for a this radical.
Lymphadenectomy.
Yes, ma'am. That we can do by abdominal route or minimal invasive surgery.
Yes, yes. Next slide, please. Next slide. So what are the principles of treatment? You have to, both the primary lesion and the potential sites of spread should be evaluated and treated. Optimal therapy consists of radiation or surgery alone. Morbidity is higher when both are combined. Primary therapy should avoid planned use of both surgery and radiation. Next slide. So you've just talked about what are the therapeutic modalities. Next slide, please. So surgery you do when it is limited to patients with stage 1 to 2A disease. And radiotherapy can be used in all stages. Then you have to give neoadjuvant chemotherapy and chemoradiation. Next slide. So in micro-invasive disease, as you said, that if she wants to preserve her fertility, then we will go for a conization. And if the limb vascular spaces are involved, then we will go for radical trachelectomy. And even if you do a cone, you have to do, I think, you have to remove the lymph nodes. Next slide, please. In stage 1A1, what will be the treatment? Suppose the woman has completed childbearing, so we will go for in elderly women, extrafacial hysterectomy may also be recommended, and any route can be chosen. As you said, you can do it via the conventional route or laparoscopically, or robotic surgery can be used. When LVSI is evident, you have to do pelvic lymphadenectomy. And of course, if fertility is desired, cervical conization with close follow-up will be adequate. Next slide. If it is stage 1A2, there is a small risk of lymph node metastasis in these cases. So pelvic lymphadenectomy has to be done in addition to type B radical hysterectomy in low risk cases where there is no lymph vascular invasion. So you can do a simple hysterectomy or trachelectomy combined with either pelvic lymphadenectomy or sentinel lymph node assessment may be adequate surgical treatment. If she desires fertility, she may be offered a choice of the following: cervical conization with pelvic lymphadenectomy, or you can do it by minimal invasive surgery, then radical trachelectomy with pelvic lymphadenectomy. Next slide, please. So in young women desiring fertility sparing, a radical trachelectomy may be performed, indicated for stage 1A2, 1B1 tumors. The cervix along with the parametrium is removed, followed by anastomosis of the uterus with the vaginal end, and trachelectomy can be done by open, abdominal, vaginal, or by minimally invasive routes. When a vaginal approach is planned, the pelvic nodes are first removed laparoscopically and sent for frozen section to confirm node negativity. Then we proceed with the radical trachelectomy vaginally. Alternatively, the nodes may first be assessed by conventional pathological methods and the radical trachelectomy done as second surgery after 1 week. Next slide. So what are the types of surgical procedures already discussed? Next slide, please. Conization, trachelectomy, radical hysterectomy. then laparoscopically assisted radical hysterectomy and lymphadenectomy, then exenteration operations and oophoropexy. When you are going for in a young woman, you are going for radiation, then you should do oophoropexy. Next slide, please. So what is conization? It has already been discussed, but can anyone again repeat it? Next slide. Yes, can you repeat it please once again?
And here we remove the transformation zone in the form of a cone, including the lesion. It
Yes.
extends up to the endocervical canal.
Yes, and it is both diagnostic and therapeutic. So next slide, please. Next slide. Next slide. So in this form, we have to remove the tissues. Next slide, please. So you are seeing that a cone is being removed. Next slide, please. Next slide. Next slide again. So have you seen a radical trachelectomy and how is it done? Next slide.
Not seen.
Can you throw some light on it? Dr. Kiran? Anyone can.
Entire cervix is removed along with the parametrium, and lymph nodes will also be removed.
And do you want to place a cerclage also?
Yes, ma'am. Yes, to prevent further incompetence if we are doing fertility sparing surgery.
And it can be performed transvaginally or
Yes, ma'am.
abdominally with lymphadenectomy. Next slide. Here it is being shown. Next slide, please. So the complications of trachelectomy are cervical stenosis, increased vaginal discharge, cervical incompetence, and infertility. Now, next slide. And next slide. So if you give a new adjuvant chemotherapy, what is the harm in it? It can damage the gonads of the patient. Next slide. So after this neoadjuvant chemotherapy, the conception rate was 80% and live birth 65%, preterm labor 28%. After this, matlab trachelectomy, I think. So next slide. So to conclude, option for early stage cervical cancer desiring for future pregnancy, you have to carefully select the patient and carefully select the operation and do a proper counseling. Next slide. So this is a question regarding that when a patient is pregnant, she is 20 weeks pregnant and has come to you and you discover that she is having carcinoma of cervix. When you did and she also complained of bleeding PV, and when you do a pelvic examination, you find a growth there. So how will you manage?
First of all, the patient is directed for colposcopy, ma'am.
No, she has a definite mass. So yes, you can go for a colposcopy.
So to see where is the lesion, whether the lesion is visible or not. If the lesion is visible,
yes,
then excision can be done.
Excision.
Yes.
But suppose she is having carcinoma cervix, 20 weeks pregnancy, and how will you excise? There is a growth.
Okay.
So I think what we used to do previously was when such type of cases used to come, continue the pregnancy till the age of viability and then go for a definitive treatment. You can do a, suppose she reaches 32 weeks and the baby is salvageable now. So you can go for a cesarean, take out the baby, and then you can go for a vaginal hysterectomy, but the radical hysterectomy followed by radiation or and chemo. This is what we used to do. Can you throw light? This is what used to be done because would you like to do a biopsy in these cases? Hello?
Ma'am, regular follow-up is required in this patient. Regular
Yes.
follow-up should be done.
But how will you confirm that she is a case of carcinoma? So, see, you will do a regular follow-up if she is having a microinvasive cancer. But if she has a definite lesion, you can see the growth. So what regular follow-up?
We can take the biopsy. Directed biopsies can be taken. Ectocervical biopsies can be taken.
Yes, you see the growth. You can take biopsy from that, but then there is chance of bleeding since pregnancy is a very vascular state. So there is chance of bleeding, but then you have to take a biopsy to confirm your diagnosis. And okay, next slide. So there are certain cytological changes which occur during pregnancy, and these are glandular hyperplasia, presence of residual cells, then area-stellar reaction, immature metaplasia, confused with cellular atypia, and increased false positive rate. But these are for in situ lesions. Next slide. So colposcopy also has increased vascularization of cervix during pregnancy. There is prominent reaction of metaplastic epithelium to acetic acid, suspicion of more severe lesion than actually is, and colposcopically directed biopsy is most sensitive. Next slide, please. So we know that the sensitivity of biopsy is 83%, specificity is 95%. Next slide. So complications, as we told, excessive bleeding, preterm labor, and chorionic amniorexis. Next slide. So can you do a CT scan during pregnancy?
Yes, ma'am.
Mom, we can do CT scan. Yes, ma'am.
So dose allowed to the fetus is 10 to 15 gyri, and dose of one CT scan is just 1 gyri. Next slide. So next slide, please. Now, suppose the lesion is HSIL. You said that you will do a proper follow-up. So monitoring will be done every 3 to 6 monthly during pregnancy using cytology and colposcopy. So not 6 monthly. I think will be 3, 6 and re-evaluation 6 to 8 weeks after delivery using the same methods. And if there is suspicion that it is becoming invasive, you will do a biopsy. Low-grade lesions regress in 48 to 62% of cases, and they remain unchanged in 29 to 38%. Progression to severe lesions is infrequent during pregnancy. Only 6% of the cases, they progress to severe lesions. Next slide. So invasive cancer, as we have already talked about, the gestational age at time of diagnosis is the determining factor, the stage of disease and size of the lesion, and whether the patient wishes to maintain pregnancy and fertility. But if it is an advanced lesion, you don't have to preserve, you cannot preserve her fertility. Next slide, please. So if it is the microinvasive cancer cervix, you have to do as you already said, colposcopy every 2 months during pregnancy, and re-evaluate at 6 weeks after delivery with cytology and colposcopy, and have to do a biopsy if there is suspicion. Next slide. So invasive carcinoma diagnosed at less than 20 weeks gestation. If it is less than 20 weeks gestation, what will you do? Immediate and definite treatment, radical hysterectomy, fetus in situ, plus bilateral pelvic lymphadenectomy. And after that, you can go for a brachytherapy, and complications are vaginal fibrosis, cystitis, and enteritis. Next slide. And if it is more than 20 weeks, so you have to wait. You have to wait for the period of viability. Then you take out the baby through cesarean section and then proceed for a radical hysterectomy. Then chemotherapy also can be done. And in other trimesters, it may cause low birth. Naturally, if you take the baby at 32 weeks, it will be premature. And due to the disease, there may be intrauterine growth retardation or intrauterine death also. Chemo is avoided after 35 weeks as delivery may occur in immunosuppressed state. And if diagnosed between 28 to 34 weeks, corticosteroids should be given for fetal lung maturity before definitive treatment. Next slide. So, for cervical cancer during pregnancy, adequate management of these patients requires a multidisciplinary team. The plan must be discussed with the patient and ideally a partner too in order to respect their wishes. Next slide. Broadly, the management of cervical cancer in pregnancy follows the same principles as in non-pregnant patients. Before 16 to 20 weeks of gestation, patients are treated without delay. The mode of therapy can be either surgery or chemoradiation, depending on the stage of the disease. Radiation often results in spontaneous abortion of the conceptus. Next slide. From the late second trimester onwards, surgery and chemotherapy can be used in selected cases while preserving the pregnancy. When the diagnosis is made after 20 weeks, delaying definitive treatment is a valid option for stages 1A2 and 1AB1 and 1B2, which has not been shown to have any negative impact on the prognosis compared with non-pregnant patients. Next slide. Now, route of delivery choice is based on the type and grade of lesion, and vaginal delivery is safe in precursor lesions as it may lead to regression, but in advanced lesions, cesarean section is the preferred mode of delivery. Next slide. So, vaginal delivery can be done in stage 1A1, and then cesarean micro invasion less than 3 mm. It promotes disease progression by lymphovascular dissemination, implantation at episiotomy site. So, cesarean section must be done at advanced cases. Next. So, what is the prognosis during pregnancy? If it is diagnosed in early stages, it is better than non-pregnant carcinoma cervix, and prognosis is not affected if postponed for fetal lung maturity. Next slide. Next slide. So thank you very much.
Thank you, Alka ma'am. That was indeed an elaborate discussion on the management. Thank you for the inputs. Now we would like to continue with the panel on screening and vaccination by Dr. Nisha Singh ma'am. Dr. Mamta ma'am, if you're there, can we have a few of your expert comments, please? Mamta ma'am. I think madam is not there.
No, I'm
okay, Mamta ma'am, you are there. Yeah.
Very much there. I was on mute. Thank you, Dr. Alka ma'am, for a very good collection of cases which can be basically we clinicians frequently encounter the various scenarios and which we put us into dilemmas as to how do we treat this woman, especially like HCIL, HCL lesions in the pregnancy, and of course where the fertility is at stake and we want to conserve. And one word is that when it is like in the first scenario, it is a HPV positive woman and HCL lesion, definitely on cytology, on high-grade lesion, you basically, HCL lesions are to be subjected to colposcopy. And here the WHO now advocates that you treat these lesions, that is 3C and treat policy, by whatever resources your permits, whether you have ablation or you have cryotherapy available or LEAP or LEDs available, whatever facility you are having, so that you do not lose these patients where the prevalence of the disease is high. In pregnancy, our main aim is the aim of colposcopy, doing colposcopy is to exclude malignancy. Here, the ECC is contraindicated, but cervical biopsy definitely should be considered when it is really a high-grade lesion or where you are having an obvious growth. And of course, the biopsies, the small biopsies are safer and there are methods to control the bleeding. Of course, the excisional procedures are better avoided in pregnancy because of the increased pregnancy complications and bleeding. Thank you.
Thank you, ma'am. Thank you, Mamta ma'am, for the very valuable inputs.
Yeah, we are waiting for Dr. Nisha now to take over.
Yes. Thank you.
We would now welcome.
It's me, Dr. Nigat. I'm sorry. My mobile was not working. I'm sorry, I could not. So I have just managed to get into the picture. It was an excellent talk. I don't think, it was very crisp and everything was so clear. And I think the panelist didn't have much role because madam was speaking excellently and everything was very crisp. And as far as these procedures of fertility sparing, we all had a consensus that ablative would be better, although with the the side effects and then premature labor and other things. But excision would be better than ablation because you get a tissue for histopath, you confirm your diagnosis. And of course, we also came to know from this that what are the advantages of colposcopy, or what is the role of colposcopy, which is either video operated colposcopy or colposcopy directed biopsy. And everything was so clear. So the next screening method would be even more clearer. So thank you so much for everything.
Thank you, ma'am. Over to you, Nisha, ma'am, for continuing the panel on the screening and vaccination methods of cervical cancer.
So a very good evening to all of you, Dr. Alka, ma'am, dear Mamta, Dr. Amita Suneja, and we have Dr. Anita Sabarwal, some very old friends, and the panelists, some known, some unknown. A pleasure to be here. And thanks to the PSC team for inviting me here for this panel. So can we have the slideshow, please?
Ma'am, it is visible?
Yes, yes. Thank you so much. So as far as the screening methods and management of the pre-invasive lesions and vaccination, this is relatively a simpler topic, and it is more of use for all the gynecologists. And I feel that my panelists will be able to answer, or not actually answer, but to contribute to this panel much more than actually I need to add points to. So let us start off with the first slide, please.
Yeah, Dr. Nisha, I'll just take half.
Yeah, please.
for disturbing you. There was a message from Dr. Nija Bhatla, so we had to announce because she was supposed to give a first talk, but because she was busy. So after this panel discussion, she would be available. So the people who are watching, at least they can join once she's there. Thank you so much, Dr. Nisha. Thank you.
So I welcome all the panelists and we'll start the session. Next, please. So let's start about, a very simple thing. What is screening? Because when we say screening, many times, the youngsters and the people who are not into it get confused with what is screening, what is diagnosis. So what is screening and what are the criteria of ideal screening method? Any of the panelists could take this up.
So, ma'am, can I take the question?
Sure.
Yeah, ma'am, screening is basically the pre-diagnostic preclinical lesions which we can detect in the asymptomatic population. Basically, here we are dealing with asymptomatic population, and we are doing so that we can detect and treat before it becomes very severe. So there are types of screening. One is the mass screening, which we do in all the population, and then there is a selective screening which we do for the high risk patients, high risk individuals who are more for a particular kind of a disease.
So the important point is, can I have the next slide, please?
Yes, would you like my inputs? I'm Dr. Nigar.
Okay, sure. Please.
As far as the rise of the global rise and what we heard in India, I would say that rather than high risk screening, mass screening would be the ideal.
Yeah,
mass screening would be ideal because it's on a rise, and we know why is it on a rise. We know the reasons for rise, all that sexual activity and so many. We don't want to go into all those.
Dr. Nigar, yeah, I think this was actually a general question about what is screening pertaining to cervical cancer screening. Of course, what you are saying that, so we were just talking about what is screening.
No. This is just. I don't want to interrupt. This is just because for everyone to know that I think mass screening should be the programs should be there. Mass screening. That's only how we can pick up, and we can just this dreaded disease could just we could just
absolutely
get
for
rid of it.
Cervical cancer, absolutely we have to.
And moreover, I mean, as far as PAP and other things are concerned, actually they are not really they can be available everywhere. And it's
so
not
we will move to the methods. We will move to the methods.
Sure.
The point is just that we have to understand, as rightly said, that screening is something that is done in asymptomatic women. For some diseases, we talk about mass screening for all population, and for some diseases, we talk about selective high-risk screening. Pertaining to cervical cancer, you are absolutely right that we talk about there is an eligibility criteria, the age group and all, and then it has to be all women in that age group. So next, please. The other thing was that do we have, does it apply that for all diseases, do we have a screening test, or what is an ideal screening test? So let us hear about that. What is an ideal screening test?
Yes.
Yeah, please.
Yeah. So an ideal screening test should be a simple test. That is, it is easily accessible. It can be done. It should be easily available. It should be relatively cheaper. It should have a high sensitivity towards picking up that disease. And if with high sensitivity, it has a high specificity also, it's good. And it should be acceptable to the population, and it should be more or less quite accurate, and we should be able to quote a number for the accuracy. And the most important thing in a country like us, it can be in for that matter in any country, it can be done by even paramedics, and it should be repeatable. It's not as if it can be a single test that can be done. So we should have an ideal screening test, and which should be easily accessible and doable. That's the most important.
Yeah, absolutely right. So there are certain criteria that, of course, to get an ideal screening test in all situations is not always possible. I would like to ask here once again that which are the conditions in which a screening test can be actually made available? Because this is the reason that not all cancers do we have screening methods. but it is particularly in cervical cancer. So there is one prerequisite to be, find a screening test for a particular disease. What is that?
Accessibility, I think, of that,
So
and the presence of precancerous lesions. I mean,
yes.
if
So
there is a disease process, it cannot be
yes,
that just hits you like
absolutely.
in
So
cancer.
that is the
So
important point, that whenever in a disease etiopathogenesis, or when the disease develops, if there is a long period for pre-invasive disease or something, then that is the time that actually we can apply the screening test to the population. But if there is a disease which comes very fast within few months or something, then it is not possible to apply. So cervical cancer is one disease where we do have a very long pre-invasive phase, or actually from HPV infection to pre-invasive lesions to frank malignancy, and that time gives us the opportunity to apply a screening test and a mass screening for this disease. Let's have the next slide, please. So having understood that this is a disease, what are the different methods of cervical cancer screening? Let us just have the names in the beginning. Later, we'll talk about them individually. Anyone can take this.
Is anybody taking it? Dr. Jayashree here. I mean, if you name somebody, I think
okay, Dr. Jayashree,
cytological testing, that is a pap smear that we routinely do. It can be an HPV testing screening. It could be a basic thing like a visual inspection by acetic acid, or it can be there are other tests available, though they are not well proven. HPV mRNA testing and some of the PEI 67 nucleic acid, which we are not doing, but these are some of the screening options available.
Next slide, please. So as you rightly said, mainly it was the cytology-based screenings that we have been doing for a long time. But over in the last, once we discovered that HPV is the cause, then the HPV-based tests came. And because of the low resource settings where these are not applicable, in the last decade or so, we had a lot of emphasis on the visual inspection. Next slide, please. Related tests. So these are the major classifications. If you see, then there are some physical methods also. Next, please. Next slide, please. So among the cytological, it is the conventional PAP that most people have seen and done, but we have the liquid-based cytology, which is available now in some places. There could be an automated cytological scan also, and AutoCyte and AutoPAP could also be there. Next, please. Among the HPV test, as you said, more commonly it is the HPV DNA test, but there are HPV RNA tests also, and there are certain tests that could be added to the cytology also, the P16, Ki67, which could increase the sensitivity, specificity of those tests, and you can do the E6, E7 protein testing also. Next, please.
Yes, and if that, P16
yes,
immunohistochemistry is done,
yes,
which obviously will not be available everywhere, and it's very sophisticated. But just for the information, if it's done, it is really, it also decides between the treatment, observation, and triage. I mean, the positivity of P16 also immunochemistry is really important, but our resources and our
everywhere available.
or not available.
Yeah, and then the visual inspection of the cervix unaided or with acetic acid or with levosiodine is are the other methods which have kind of, they took over. They said that WHO also said that they could be the second alternatives, although now we are in a situation that we say that the best is the HPV test. Next, please. And then the colposcopy, and then the mobile, versions of colposcopy, you can say. Colposcopy has been a diagnostic test, basically as a triage test, but there have been development of these mobile kind of devices which can be used for colposcopy, and so they could be helpful as screening tests also, like the binocular, the cervicography, videography, and spectroscopy. Of course, as you said, availability, and then these are the newer aspects that are coming up. Next, please. And then among the physical methods, we have the TrueScan, fluorescence spectroscopy, and autofluorescence. This is only to enumerate and have an idea that what new is coming up. We'll talk more about the things which are commonly used. Next, please. So tell us about the PAP test, advantages, disadvantages. In current scenario, where does the PAP test stand?
Of course, PAP, I think PAP is a gold standard.
Mm-hmm. Would you like to say it is the gold standard?
No, I don't say PAP, HPV and PAP co-testing or PAP, but in our country, I think PAP, as we rightly said, it's an ideal and easily available specificity, sensitivity, keeping all those things in mind. It can be done by anybody. Don't need a really great training for it. So PAP is one of the tests which.
Any other opinion? Any other panelists to give another opinion?
Because yes,
No,
anybody?
It's okay, Dr. Nikat. Anybody
Yes.
who wants to give some other opinion on this?
Dr. Jayashree here, I
Yes,
think
please.
if we want to use it ideal testing, PAP has its limitations. You need an infrastructure to check on the PAP result. It doesn't come immediately. It is not a see and treat method in low resource countries like ours. So ideally, if we want to screen all women in this country with proper training, it should be visual inspection by acetic acid. It is much cheaper, and PAP does have a lower sensitivity. Sensitivity is quite low for PAP. So whether we do it, so we always have this belief LBC might be better than conventional PAP, which is not true. LBC is more convenient to do, whether or the sensitivity remains the same. So it has its limitation. PAP has its limitation. Many countries, HPV has been taken over as the primary.
Yeah.
That's right. So what Dr. Nigat said, that it is an easy test, anybody can do. So if you just think about the sampling part, of course, it's an easy test.
Yes.
But if you think about what happens later, the sample goes to a cytologist, to a laboratory, the cytologist has to stay in and then prepare this, see and then
that is those
that
are
way.
the.
So those are the reasons. Actually, those are the reasons that this is one that you need a lot of infrastructure, because it's not a test which is just observer dependent one. So apart from that, the sensitivity and specificity also, if you see that compared the sensitivity particularly, it is a specific test, but sensitivity wise, HPV test has a better sensitivity. And these are the reasons. And then over the years, we have been doing PAP. We have been using PAP test as V means world over, but then there have been limitations. It is not able to pick up and manage all this thing. And that's why there was people had to discover newer methods and better methods, which could, which could give us a better diagnostic accuracy. So a screening test, yes, as far as availability in India is concerned, whichever institutes or organizations have something, this is what we were having. This is what we were having. But then now the newer things have come up, and we are here to decide that if we have to change over or we have to start anew, then it will not be a PAP-based cytology, but something else that will be there. So otherwise, over the years, it has been one of the most commonly used screening methods. So coming to the second point, which Dr. Jayashree raised about LBC. Now, liquid-based cytology, yes, truly sensitivity, specificity does not change. Cost is a factor. So to change over to this, you have to have the machines available. But the only greater advantage is to the pathologist, because that is an automated test, and a lot of inadequate smears, or actually the so inadequate reporting is much less in the liquid-based cytology. So that was because the mucus, blood and all, it kind of in the liquid-based, it washes off and you have only the cells. So for the pathologist, it is much more convenient. So wherever it is possible, people have switched over. If they are still on the cytology, then switched from PAP to liquid-based cytology. That is the concept about
one more advantage with liquid-based cytology is that the reflex HPV testing can also be done with
that
this.
is another thing, right? Now, coming to the next test. Next slide, please. So these limitations, we have talked about them. If there is anything left, we can just, it is not so helpful in the menopausal years, again, because of the, taking in of the transformation zone, not very well sampled in that. And next, please. So how is the PAP test result interpreted? How do you report it? Anybody would like to take that? Next, please. So we are doing this thing on Bethesda system, and the different types of abnormalities that are reported in that are the atypical squamous cells, L cell, H cell, squamous cell carcinoma, and you have the atypical squamous cells of undetermined significance and the atypical squamous cells of which have high probability of being malignant. Next, this is a very simplified version in this slide. If you see that whole the forms, those who are using Pap smear as or LBC as a routine reporting, there are you can see the different types of reporting that you get. So now, which is the primary screening modality recommended nowadays? Recommended, if you go by WHO, what is, or IARC, which test? Some people said also it is HPV test. So just talk about that a little more. Anyone? Is any one of you doing the HPV test? No one is doing, probably. It is freely available in the
it is HPV. Yeah, hello. HPV test we are doing, but not as a primary screening method till now, but we are doing and using it for triaging also. When we find ASCUS report, especially in a woman, we use it for a triaging purpose, and people who can afford and cannot come back and can afford an HPV testing, we are offering a routine HPV testing above the age of 30, and so that they can come back for a recall after every 5 years. Right? Provided the PAP is negative. But if the HPV is negative and the PAP is positive, then we have to refer them to for further screening methods. So HPV is being done in this country. It has its cost implications. So many times we are using it for triaging and not as a primary screening method.
So any other comments from anybody about HPV test? All right. So actually, if you see the literature and if you see that, through all the literature, it says that HPV test is the best screening test, despite the cost that we think about starting off the test, the equipment and all that is required. But when they do a cost-effective analysis over the years, they realize that the cost is not higher because the frequency of testing reduces. Because compared to cytology, which is supposed to be done every 3 years, HPV test can be and should be done every 5 years. That is one reason. And with the newer recommendation, as WHO says, that maybe if even twice in the lifetime, once around 35 years and once around 45 years, if a woman gets twice this tested, it is good enough to, as a screening test and a screening guideline. So cost becomes a factor in the initial, this thing, if you think about a one test, but if you think it over the time, it is not a very costly test. Of course, availability, definitely. In the private sector, it is costly as each test. So some places, and there are various methods, there are HPV DNA test, RNA test, and then there are tests which are PCR based test also, but there the quality assurance is important. And sampling, of course, is like you do for the LBC. You have a broom test, you have a broom that with which you take the sample from the ectocervix, and it takes some few cells from the endocervix simultaneously, and you have to put it in that bottle, detach the brush, and send it for analysis. And it is an automated test again, and it looks up for the high risk HPV types that would be present. The same can go for a triage of 1618 if the facility is available. So current status is that HPV test is considered to be the best primary screening modality. Next, please. Sensitivity is as high as 45 to 80.9%, specificity 91 to 94%, high negative predictive value and high test reproducibility that is there. Then we have got tests which could be the done by the healthcare worker, or they could be self sampling also, because the care HPV or things are also, that is another advantage, that woman can take her own sample also, because most of the times the screening programs fail because of the hesitation of exposing themselves for the screening test. Next, please. Next, please. Yeah, so the hybrid capture to test that is available, which is FDA approved, less demanding in terms of training and quality assurance, and detects whether the infection with one or more of the high-risk types I mentioned, and then the care HPV, which I said about the self-testing and self-sampling, and also the test comes very fast, the report comes very fast. Next, please. But then, because as we are always talking that we do not have the availability of HPV DNA test everywhere, and all cannot afford in the current prices that are available in the private sector. So what is the next alternative? Let's talk about the visual methods. Anyone? Anyone can take this, please. Those who haven't answered till now are welcome to take it up. The visual methods.
So,
visual methods would be VIA and Willy. Those would be the two.
Yes, yes. So you can talk about the principle and what are the advantages.
Obviously, it's coagulation of the proteins, and it makes it, when we do it with acetic acid, it coagulates the proteins and makes it white, and easily we can pick it up. And of course, it's simple. Cost wise also it is simple. Then as infrastructure is not needed that much, and of course results are comparable. You can say comparable to PAP. It's not very tedious thing. Whereas about the Veli Legols iodine, the principle is that the tissue glucose deficient in the malignant cells, and the staining is according to that. So it is also quite a reasonable way of examining.
Okay. Anybody to tell the disadvantages of these tests? Anyone? All right. So as you said that the visual inspection with acetic acid, it is protein coagulation. So because the abnormal cells will have higher protein and the protein will get coagulated, so the abnormal tissue will appear dense, opaque, white. And so we do this test and we are able to identify the abnormal lesions. So it is like one step ahead. Like with HPV test, you are looking for the infection, whether it is present or not, while here we are seeing the effect of that infection on the tissue. So the changes that happen in the tissue, which are reflected by the application of the acetic acid, are seen. So that's the principle. Now strengths, most of the points you have covered, but when I was why I said that it is easy, but a training is required. It is observer based test. So one that is an advantage also becomes a disadvantage, that somebody who says, there has to be adequate training to learn to identify the abnormal lesions. And so, identifying the lesion, and then, so the false positivity may be there in these cases, and it is because it is observer dependent. But among the advantages, one good advantage is that if you apply it in the community setting, then the screen and treat strategy can be very well utilized with these tests, because you do not need much equipment and you can use this test and do it. Now, if we want to take up HPV test as a primary, then in that case also, the newer guidelines say that you test with HPV. Those who come positive, instead of going straight away, screen and treat, you do screen, triage and treat. In that case, with HPV positive, you must do a triage with VIA. If you see the lesion simultaneously, then only treat. So that is another utility of the VIA test, which will remain even if we switch over to HPV test. I hope I have made myself clear with that. So that's another thing, so that these tests will aid as triage methods also. And also to decide that what method of treatment should be taken, whether it should be ablation or excision. So for that, VIA will still remain as a middle point after the HPV in the screen positive, HPV screen positive conditions. And villi, as you said, yes, it is a test, but individually, independently, villi has not been, found to be as suitable as a screening test. Usually, we add to VIA, but VIA itself has been considered as good alternative to HPV test. So first is the HPV test, and second remains these visual tests. Cytology goes down now in the current scenario with the limitations and with the requirement for the resources and all that. Next, please. So, of course, in this panel, if anybody wants to, talk about the scoring or what are the aspects that we see in a lesion, the aceto-white lesion, what are the characteristics of a true aceto-white lesion, you can just talk about that. How do you identify that it is a VIA positive case? So it's not just the appearance of a whiteness. It should be a dense, opaque white lesion. The lesion should persist. And when you apply the acetic acid for 1 minute and after that it appears early and remains for some time. And the margins are clear, sharp and distinct margins. These are the positive lesions. But on the other hand, if you just see that there is some whitening that is very patchy or it is very faint, margins are not clear, then it is not a VIA. So this is what is the requirement for training people to learn this. Though medicos as well as the paramedics can be treated, but can be trained, but training is required to learn how to identify. And also there will be a lot of other things where whitening would be there, like the polyps sometimes, like the endocervical area, that will, so the lesions in the endocervical area will not be considered as aceto-white. It is particularly the transformation zone. So identifying the transformation zone and trying to see, sometimes with metaplasia also there could be some white lesions that will be closer to the inner margin that will be there. And also people have to learn that what is a suspicious lesion, which is called suspicious of invasion, a one which is ulcerative or a cauliflower-like growth or a growth that bleeds on touch does not have to be treated like a VIA positive lesion by these screen and treat methods. Rather, they have to be biopsied. So we cannot cover everything in this panel, but these are the important aspects that one has to remember when you are comparing the various screening methods. Next, please. So limitations, as I said, many false positive results and unnecessary treatment. Training and quality measures are required and less accurate in postmenopausal women. Again, because again, the transformation zone is not fully visible in the postmenopausal women. Next, please. Now talking about colposcopy, anybody who wants to talk about colposcopy, which...
So ideally, colposcopy is magnified, as Dr. Jayashree,
Yes.
magnified image of the cervix, right? So obviously it is quite sensitive and more cost effective, but needs training to be done. And it should be done obviously in positive screening cases. And the best thing is you can take targeted biopsies. You apply via belly, you see the blood vessel, the arborization of vessels and everything. You put a green filter and you can take a biopsy from the suspicious areas. And obviously, when we have taken a biopsy, we can see and treat at the same time. So that is the advantage of using a colposcopy, and it is indicated in all This where we have had a
साइलेंट करो ना, इधर टिपिकल चीजें चलती रहती हैं। हाँ बेटा देना इनका अल्ट्रासाउंड, दोबारा ये बना देती हूँ।
Dr. Sonal, could you please mute yourself?
दिखने लग गया है, दवाई दे रही हूँ,
Somebody
ले
mute
लेना।
Dr. Sonal.
फिर मुझे लेकिन अगले संडे, फिर नहीं तो मुझे ऐसा है कुछ 6 बजे के बाद दिखा के जाना किसी दिन, अगले थर्सडे दिखा जाओ, जब बीच में ब्लीडिंग अच्छी हो जाए तो।
Yeah, Dr. Jayashree, please continue.
So that is what I said, that if it is a pre-malignant lesion, it can be treated in the same sitting. So obviously colposcopy becomes a gold standard, and it has its own curve of training also that needs to be done. You should know how to handle the equipment, but it is a wonderful equipment, especially in the pre-malignant lesions, and a tool to be used when we have any screen positive woman who needs that.
Absolutely. So this is the diagnostic method to confirm your findings of the screening, and also to be used as a triage method. If you have a colposcope and a screen positive, must go through a colposcopy, and then if there is an abnormal lesion, as you said, you biopsy and simultaneously treat it also there. So that is it. With the entry of the mobile colposcopes, the various devices that are there. So the triage is actually available in the community setting. So that is how these devices has come up. Otherwise, the proper colposcope, the standard colposcope that is stationed at one place in our hospitals or settings, that cannot be taken. So that's why these mobile devices came, that if you have to triage, that you can do. So they work as both screening as well as diagnostic method there. So next, please. Next slide, please. So which test is better for screening? How to compare their efficacy? We have discussed them in detail. Let us just have a slide comparing the three of them. Next, please. I think this is like, the color of this thing is a little distinct. But if you see the PAP test, if you see the sensitivity is 52%, VIA is 91%, and HPV is 86%. So that is how the difference is. And that's why we were saying that the sensitivity wise, PAP is not a very good test. And similarly for the other diagnostic parameters also. Next, please. So screening is the backbone of cancer prevention. And as I said in the beginning, this is one disease where we are fortunate to have a pre-malignant lesion and a long time of about 10 years, which it takes from the HPV infection to conversion to pre-malignant and then malignant. So screening is very useful in cervical cancer prevention. Cytology is proven successful tool for secondary prevention, but VIA villi should be popularized for low resource settings. But this statement, I should say, we were saying this about till our 2 years back, but now since all the guidelines, everybody says that HPV test is the primary, is the best suited primary method of screening. Now, even in the low resource settings, you just have to understand the cost benefit analysis. So screening should be continued even in the post-vaccination, that we all know that even with vaccination coming up, this will continue. Next, please.
Ma'am,
yeah.
Ma'am, we'll be running short of time. So
we'll leave vaccination. Yeah.
Yes, ma'am.
No problem.
Mamta ma'am, can you please give your expert comments for the panel discussion?
Yeah, so thank you, Dr. Nisha, for a very elaborative review of the screening methods. And just to be really very short, you shall be doing the screening, though the WHO has said HPV is the primary screening method, but we know there are hurdles with HPV, there are cost issues and all. So you shall be doing the screening as to whatever is available with you. If cytology is there, do with cytology, PAPS or LBC. If VIA is with you, then do with VIA, but screen all the women who are coming to you. Absolutely. And the opportunistic screening so as to cover the maximum. Thank you.
Very rightly said, Dr. Mamta. Screening has to be done, whatever is the method. Thank you so much.
Thank you so much, ma'am. Thank you, Alka ma'am, and thank you, Dr. Nisha Singh ma'am, for conducting such an excellent panel. And thank you all the panelists for being so interactive. Thank you, Mamta ma'am, for your expert comments. We now move forward to the next academic session, which is a talk by Dr. Nirja ma'am. Shatabdi, can you introduce? I will call up Nirja ma'am in the meantime. Hello. Chairpersons for the session are Dr. Jaiswal ma'am and Dr. Anita Sabharwal ma'am. Can we have their CV slides, please? Yes. Dr. Jaiswal ma'am.
I'm here. Good evening. I'm here.
She is the president of LGS in the year 22-23. That is the Lucknow ABGY Society. She is also the president of the ISOPAB Lucknow branch, the vice president of the Lucknow Society from 17 to 20. She is a member of many associations and she has given many national and international lectures. She has also received the Best Paper Prize in the Journal of Obstetrics and Gynecology in the year 13-14. She is a visiting professor at D.P. Khorala Institute of Health Sciences, Dharan, Nepal. She is also the visiting professor at the ICOG Visiting Professorship in the year 2020. We welcome you, ma'am.
Thank you. Thank you so much.
Yes. Yeah. Our next chairperson is Dr. Anita Sabharwal, ma'am. She is the coordinator for Public Awareness Committee Fogsi for the North Zone. She is also the president of the Forum of OBGYN Societies of South Delhi. She has been the chairperson of the Public Awareness Committee of ISCCP in the year 1921 and the past chairperson of Adolescent Health Committee. We welcome both of you to please share the session for the next.
Thank you, Dr. Monica. And with the permission of Dr. Jess.
Hello. Hello.
Yeah.
Yeah, there's a problem in connection.
I would like to introduce. I can be great on Dr. Nija.
I'm audible. Please, I'm audible.
Yes, ma'am, you're audible.
Yes, okay. So this is my proud privilege to introduce Dr. Nirja Batla. We all know her. She is a well-known personality. She's having lots of work in malignancy, especially cervical cancer. She is as a tool to develop the protocol also and guideline also. So I don't think she is having, we have to introduce because she is a well-known personality. Still, I want to say something about her. At present, she is a professor and head of the Department of Obstetrics, AIMS, New Delhi, and she's a council member, Asian Society of Gynae-Oncology. She's member WHO DG's Technical Expert Group of Cervical Cancer Elimination Program. She is a Fogsi Vice President elect North Zone 2024. 2024 की बात कर रहे हैं. She's a past president of FIGO, Fogsi Gynae-Oncology Committee. She's a Secretary General of IFCPSC and President Association of Gynae-Oncologists of India. So she's having long list which is associated with the malignancy, and her talk is on the cervical cancer screening. We heard a wonderful panel discussion by Dr. Alka and Dr. Nisha that was on the screening. And we know this is the only cervical cancer which can be preventable by proper screening and vaccination and early management. So, Dr. Nirja Batla, we are here to listen you. Hello?
Hello, can you hear me?
Yes,
Yes, we can.
Most welcome.
We can see you, we can hear you. And you are the pride of Delhi, you are pride of a country. And you really
definitely, she's the pride of country.
World famous.
Not only Delhi, to all of us.
That's what I said. Delhi because our place, and then a country, of course, our Fogsi. Everywhere she has taken us. We are very eagerly waiting to hear you, Dr. Nisha.
Thank you so much, Dr. Anita. Thank you for so much for this invitation to be here today, and to all the Fogsi leadership and Dr. Jaiswal for your very kind introduction. I'm sharing my screen now. I hope you can see it.
Yes, we can.
Yeah, your screen is visible, but please make it full screen.
It's this much only, ma'am.
Yeah. Now it is.
Dr. Niranjan, also my predecessor in Fogsi committee, so many things we've done together, so many we will continue to do together.
Yes,
so
it's
just such a pleasure to be in this audience, this group here today of very motivated people. I could join in and hear this panel by Dr. Alka, so beautifully done. And it has made my task actually very much easier. In fact, you will wonder what I'm doing because you have learned everything now. But just to recapitulate some very important points only, I will proceed. I don't know why this is not. So, there is so much sometimes discussion on whether or not cervical cancer is a priority. And sometimes this stems from the fact that we don't see too many cases coming forward on a day-to-day basis. But facts are facts, and it is still the second most common cancer in females. Although, as you can see in this chart on the right side, it has been overtaken now by breast. And it is a harsh fact that breast, cervix, and oral cavity, the brown one, which are actually the 3 cancers in our national screening program, are comprising half the pie. It is surely a needless suffering. And a lot of our present guidelines come from this declaration made in 2018, rolled out in 2020, that we must target by 2030 to, and that's not far away, we're already halfway through 2023. So by 2030, we should have in our countries these targets in place.
Can't hear Dr. Nija.
You can't
hear you. Now
it is audible.
Now is audible.
Okay.
All right. Shall I go back or you could hear that one?
Just one slide. Yeah. One slide. Okay.
I am having some reason, a problem in moving these slides. Okay. So, the testing to move to HPV testing, even in low resource countries, was the biggest declaration. And it is a sobering fact that so many of us actually, there is no dearth of goodwill among our gynecologists. And we go out time and time again to do camps. But how many times are we able to follow up those women? How many times we are able to collect the reports and go back and catch those women? Sometimes we can't find them. They were visitors to their family, relatives. They got to know a camp is coming. They got the test done and gone away. Now, sorry, we can't bring her. Sometimes some other reason. But the important thing which has come from this global strategy is that not only you screen 70%, but 90% of those who have a problem should be treated. And it has been the wide experience that when you go into an unscreened community, about 6 to 7% are positive. Whether you do PAP, whether you do HPV, whether you do VI. But what is the difference in the test? The difference is the assurance to the person with a negative report. If you are PAP negative, it doesn't mean that you don't have disease. That is why you have to go so many times, because sensitivity is just 50–60%. If you do VI similarly, it comes negative. It doesn't mean you don't have disease, because it might be in the canal. It might be that you couldn't see the changes yet. But HPV, if it is negative, not only that you are ruling out that there is not disease now within the limits of the test, no test is perfect, but also if you don't have the virus, the likelihood of developing the disease in the near future also. And this is the reason why WHO has said, find a way to do HPV testing. Even if you do it only twice, at age 35 and age 45, forget the 5-yearly, just do it twice in a stable relationship. She's not getting married again, everything good, 2 tests and out. And in fact, Dr. Shankar's studies showed that even 1 test in a lifetime made a dent. But I will say, let us target this based on a lot of evidence, lot of large studies. This has to be the goal of every Fogsian, that we find a way to transition, not just for patients coming in our clinics, but also when we are going out in the communities. Find a way to find donors who will support the HPV testing, and find a way to engage with the local NGOs so that the positives can be treated. This is my most important message. And WHO has been saying this screen and treat since 2015, when they said, make it a screen and treat program, try and go to HPV. If your cytology is not meeting the quality indicators, try and move to HPV. But if you can't move to HPV, do the VIA, but carry your cryo. And now we are on the thermal ablation and have the resources to do a screen and treat. So there's a whole plethora out there of screening guidelines. Mostly, I will also focus on the WHO 2021, but you have already discussed it in detail with Dr. Alka, so I will not bore you with repetition to the extent possible. And just to tell you that many other societies have had their guidelines revised in recent past. But again, you see with the Americans and their differential way of life and their cancer patterns, they say start at 21, somebody says start at 25. WHO is very clear, and so are we, that the target is 30 plus. We have scant resources. Let us not waste them on the women who are younger. Why? Because if we look at the cancer curves, there's hardly any cancer under 30. I'm not saying that the patient who comes with a complaint to you, she says, I have persistent discharge, she says, I have postcoital bleeding, she says, I have postmenopausal bleeding. These are all symptoms that are bothersome and they have to be investigated. They are very suspicious. But when we talk screening, we talk about going in the normal population and going to every woman and saying, come get this test. We don't care whether you have a symptom or you don't have a symptom. That should start after 30. And as WHO has said, 35. Now, other point being that under that age, a lot of women may be having HPV, which their own immunity will clear out. And HPV clearing takes time, not like flu in 1 week, not like COVID in 2-3 weeks. It takes time, and it takes up to 1 year to 2 years even sometimes to clear it out. So if you go to the very young ones under 30 group, then they may have HPV, which they would have cleared given a normal immune response. But if we then find positive, then there are harms of screening, of unnecessary treatment, of unnecessary psychological impacts also. Oh, I don't know how much infection I have. I hope I don't pass it to my partner. Or why? How did my partner pass to me? All unnecessary talks to go on. So focus after 30, preferably stick with this new guideline, 35 and 45. And then even the costs even out, because you just have to do it twice. So even if it is more expensive than a PAP, but over time, it comes to the same thing or better, even better. Now, the Fogsi GCPR, which we had done in great detail in 2018, have been revised and released recently. And we're waiting for the final charts to come, which we can show you. And of course, we have the Health Ministry's operational guidelines from 2016. So this GCPR, which we had, is actually widely used in many LMICs in Asia and Africa. Bangladeshi colleagues have said they are waiting for our GCPR. Recently, in one of the webinars, our president-elect of FIGO, Dr. Anne Chiara, said that Kenya, they follow the Fogsi guidelines for everything. So our GCPR are quite robust, resource-based recommendations, which we had classified in two parts as good and limited resource. And good and limited resource, we said, also means I am today sitting in my fancy tertiary hospital, I have everything, but today I am going out into the camp, I have practically nothing. So the same me also changes from good resource to limited resource depending where I am for the day. So that way it helped us. And we also adapted that WHO guidance to say that if your hospital can afford HPV testing, do that. If you're doing good quality cytology, don't leave that. But look at what facilities you can have for triage. If nothing, then you can still do VIA. And again, we emphasized this ablation or excision. So you see, by the time we came to 2018, we were talking about thermal ablation, some, but not enough. And we were still talking a lot about cryo. But today we really want to emphasize that everyone should have a portable thermal ablator. It is such a good device. And it is so helpful to women who are suffering from ectropions and discharge and all of that. And of course, for the national program, it still continues to be VIA. But I have to tell you that we are working very actively right now with DBT to do a national, international standard validation of the new HPV indigenous tests so that we can transition that also to HPV testing. So this guideline you've already seen and heard today. But for those of you who may have joined late, I can tell you that this was an up-to-date evidence, you know, they sort of updated from 2013 and kept in mind this 2030 target that we have to link screening and vaccination, screening and treatment. And we have to see that how those people at the last mile facilities, even the health workers, and it was a very systematic methodology with a guideline development group, which I had a privilege of being a part of through the COVID long online meetings, which developed the PICO questions and looked at the literature extensively to make these. So definitely you can trust that each of these is based on guidelines and it's a living guideline. They keep adding new information to it. There's a separate recommendation for women living with HIV. This is something which all our gynecologists, it's our blind spot, and we must liaise with our ART colleagues who are running the HIV services, with the NGOs which are running services, because these women have 6 to 7% positivity of the test, but 6 to 7% positivity of high-grade disease and cancer. They have very high prevalence. So we must reach out to convince our colleagues in the HIV departments to get send us the patient for screening, or better still, fix it up at their facilities in a camp-like approach. And this will be a huge service that we will do. So this I will definitely emphasize to all of us. And these screening and treatment approaches, they came out finally with the 7 of them. And each of these has an evidence to support it. So you see no test being perfect and every test being fine if done in a particular way, like we mentioned about PAP being done repeatedly and all of that. So there are evidences to support each of these as the primary test and how you can use it in a screen and treat strategy or a screen, triage and treat strategy. Now, it's very interesting that when they look at the cost effectiveness of it on a large scale, it is the same whether it is screen and treat or screen, triage and treat. Why? Because in the screen and treat, you treat a lot more people because every positive gets treated. Whereas in a screen, triage and treat, you spend something on the triage, whether it is colposcopy, whether it is genotyping, maybe if neither, maybe VIA. Also, sometimes people have done HPV followed by colposcopy directly or HPV followed by cytology. So whatsoever you are putting, the second test has a cost, but it whittles down the number so that fewer people then require to get the screening, the treatment done. One important difference between the HPV DNA tests and the RNA tests is that so far there is no evidence about RNA in self-sampling. So self-sampling being the other big thing which you can use in your practice for women who are shy, do not want to be examined. Some of the older women don't like it. We can allow them to collect a self-sample from the vagina and they can actually use the same brush. We can use this in camp settings, maybe not necessarily as a self, but as a health worker collecting a vaginal sample, which does not require speculum, does not require light source. Now, how do you take the self-sample? You just introduce the brush as far in as can go and twirl it the same 3 to 5 times and pull it out. And we have found, and so many meta-analyses have found, a good 94-95% concordance. So it is non-inferior to the provider collected, although the provider collected is possibly the best. And in the visual methods, the interesting thing is that there's a lot of AI coming in, although that has not yet been considered for paucity of evidence in the guideline. And in the pap smear, the conventional and LBC actually don't perform any differently for the detection of high-grade disease. Much easier for the pathologist because it's a clean smear and it allows the same sample to be used also for HPV testing if you need it as a triage or as a co-testing. But generally now we have moved beyond co-testing because now mostly the HPV tests have been validated. It is clear which are the good tests. And if you use those, there's no reason to double the cost. Do the HPV test and look after the positives only. So this is what I mentioned about the 2 approaches and about the various modalities and the importance of shifting to primary HPV testing. And in this strategy, we normally with PAP used to say stop at 65 years. Here, after the age of 50, if there are 2 consecutive negative results of HPV, you do not need to continue any further. With the HIV women, we do recommend that you start earlier at the age of 25 years. And here, basically, you should do it twice as often as the normal. So I'm not really going into these detail of it, except to say that these charts and this whole manual, in fact, is available as a free download on the WHO site. And you can see they are very simple charts, easy to follow, and you can see how you have to, whichever strategy you take. Just a word about the portable colposcopes, which are becoming the greatest new development. And here, these are the 3 which we have worked with. Gynocular was there, but it closed down because of some problems amongst the owners. It's actually an interesting story. But the Gynocular had software which had been developed in India. And that developer has now gone on to produce, interestingly, the GynEye, which is a new one which we are trying out, which will have the same software as the Gynocular, but a different design. And this pocket colposcope has been such an amazing development. It looks like a transvaginal ultrasound transducer. And these are all the buttons that you need. And that's it. The camera, the light, the green light, the zoom, everything is there. And what beautiful pictures you get because you go right up close to the cervix and you see it in amazing detail. And now with the artificial intelligence, we have smart scope, we have mobile ODT, and we are also investigating a new device which some of you who may have gone to ISCCP may have seen it over there as well. This is again a very beautiful device which is so easy. It tells you the steps, what you have to do next, helps you to capture the picture. And we are working with them to feed images to have AI, which will say, yes, treat the patient, or no, you can refer this patient and she does not need treatment. So already a lot of discussion has been done. One sentence I want to say only, that in fact the guideline committee, when they reviewed the literature, found that the LETs and the cold knife had equivalent results and conization was not necessarily required. So it was amazing that their outcome turned out same. So don't feel too bad if you don't have the conization skills, but every gynecologist should be confident to do the LETs, because if you can do TLH, LETs is definitely far, far simpler. And of course, this is it's important to emphasize the follow-up, which is important. And again, HPV test is actually the best test for the follow-up, because the structural changes change this look and the cytology and the colposcopy, etc. But more or less, it's the same. So I will stop here. Thank you very much for this opportunity to be here today. And if there are any questions, I would be quite happy to answer them. And can go in the chat box or whichever way you want to do them. Thank you, Dr. Anita, for inviting me for this.
Thank you, Dr. Neerja Bhatla, for this wonderful lecture. And you are the ultimate word for us, you know, because so many, as you just showed that slide, that guidelines also keep changing. And we wait for you to say something so that we can follow you. And you have been working for the last 35 years in this field of preventing gynae oncology. And I am working at a very primary level for the last almost 39 years now. And you're so very right, you know, that we at low resource area settings, we face so many problems. So you made it so clear today. But HPV, as you have convinced us by telling, because if we tell patients at my kind of areas, even once if they get it done, it will compensate everything. And here we all can also help them, and we can involve the other society people and so many even companies. So you are right. And now under your flag banner, we are all going to go further and get rid of this. So wonderful lecture. I have recorded many slides, so we'll put it up and we'll follow.
Thank you so much, Dr. Neerja. And really, it is an excellent talk. And you have summarized all the things in a very few minutes, because it started from the periphery, the low resource, to the higher. So now you have given some pics of current AI also, because now the era is of artificial intelligence, and they themselves, whether the biopsy should be taken or the treatment should be done or not. So, but still, as we know, the population varies from even we feel that the patient comes once to us, we want to see it in the gynae OPD, because sometimes they come only once in and this is a opportunistic screening we do. So definitely if every gynecologist feel that every patient should be, every woman, whosoever is coming to us would be screened, definitely we will be able to control all these things. Thank you so much. Thank you. Your excellent talk.
Thank you, ma'am. Thank you, Anita ma'am and Jesper ma'am, for sharing the session. Thank you, Neerja ma'am, for an excellent deliberation as always. We now move forward to the next academic session by Dr. Niranjan Chavan sir. Chairpersons for the session, Dr. Amita Suneja ma'am and Dr. Vidhu Modgil ma'am. Can we have the CV of Dr. Suneja ma'am? Yes. She's a director, professor and head of the department at the University College of Medical Sciences at the Guru Tej Bahadur Hospital, Delhi. Madam's fields of interest include gynae-onco, urogynecology and adolescent gynecology. She has been the president of AOGD, the chairperson of Oncology Committee of AOGD, the president NARCHI Delhi from 2014 to 16, and she has been the editor of AOGD in the year 2007. She has also received a WHO fellowship in gynae-oncology in MD Anderson Hospital, Texas, USA. And she has been the recipient of many awards. We welcome you, ma'am.
Thank you.
Ma'am, Vidhu madam is not there, so you can go ahead with the introduction of sir.
Okay. Very good evening. And after the mesmerizing talk by Dr. Neerja Bhatla, I welcome you all to the last session of the day. And that is the third pillar of WHO elimination program, that we must
treat the pre-invasive lesions and the early cancer lesions. And the topic is the surgical treatment of CA cervix. And you know, in early stages, the cancer cervix can be cured by the surgical treatment. It has many advantages over radiotherapy in young patients. And in recent past, many changes have taken place in surgical management. The role of, like, they are going towards to less radicality in early cancer, role of sentinel lymph nodes, and there's a controversy about the endoscopic surgical management. So to deal all with these dilemmas and the recent updates, we have the renowned speaker and Dr. Niranjan, and very eminent speaker. He has, I can see from his illustrious CV that his passion is endoscopy and oncology. And sir is unit chief and professor at Sion Hospital and the Medical College. And he has been very active member of Fogsi, of MOGS. He has been the president of MOGS, and he has been representative to AOFOG, actively involved in SAFOG. Sir, we are really glad and privileged to have you as a speaker for cancer cervix surgical management. The platform is yours.
Thank you, Dr. Amita Suneja. Thank you, Dr. Monica, to invite me, and Dr. Anita Sabarwal. Madam, nice to meet you after a long time, and it's wonderful to be there in Delhi. That's what I can make out, North Zone. And Fogsi PAC is doing a wonderful job. Thank you to Core Connect to get all of us together. And I also have met today Dr. Nirja Batla, and really a wonderful lecture given by her. I was in between also for the panel discussion, and it was really nice to see all of you connecting together. So our whole goal as a professor or as a teacher or as a gynecologist in India is to reduce the incidence of cancer in our country. Because in India, every 7 minutes, a woman dies of cervical cancer. And luckily, in the last decade, a lot of things have changed. The management, to certain extent, has been the similar one, which I will be taking part of. And of course, the prevention, the screening modalities have changed. Thanks to Dr. Nirja and her team at FIGO. And we are very proud that was at the helm of affairs during Dr. C.N. Purandare sir's time, and the efforts which have been taken by her committee to totally change the classification, which I will also speak about, and then the further management. So we are supposed to be supporting the fighters. We are going to admire the survivors. We are going to honor them, and we are never going to give up till as we take the oath of Hippocrates as a gynecologist, as an obstetrician, to treat our patients. So briefly, if I'll just go back, which all of you might have been aware of, but cervical cancer is the third one. The first one is breast, second is ovarian. The fourth one is ovarian, and we have the third most common, which is the uterine cervix. It is the most dreaded disease, and most of these patients are coming in an advanced stage to our OPD. I come from Mumbai, Sion Hospital, which is in between the Western and Eastern Express Highway, and we cater to all type of patients, middle class, lower class, and they come from all the stratas of society. We have about 14,000 to 18,000 deliveries a year, and of course, we have a lot of cases of cervical cancer, but somehow in the last 5 years, the incidence of cancer has gone down. So it's really quite heartening to know that the screening has taken place. The Municipal Corporation of Greater Mumbai, the Maharashtra state, and also the other states in India have taken a good approach towards see and treat and screening and HPV vaccination. So we need to lower the incidence of cervical cancer and reduce the age-related mortality which occurs. But still, it's a long way to go, and I appreciate Dr. Nirja Batla that the efforts which she has taken, and also 2030, we need to reduce further the incidence in this present decade. Human papilloma virus is the most dreaded one, which we are working on that, and that cause about 99.7% of cervical cancer. We are all aware that the cervical cancer is of two types. The commonest one is the squamous cell carcinoma. 70% of it occurs, and the adenocarcinoma, it is worse than squamous cell carcinoma because the prognosis is poor and it is not radio sensitive or chemosensitive. So that is what, and by the time it is diagnosed, it becomes too late. Now, this is the Globocon 2022 picture, which you can see the age standardized incidence of cervical cancer per 1 lakh woman years, and India, African countries, and South America, we fall into that bracket where there is still higher incidence as compared to the European or American countries. Then we see the picture low down below, which is the mortality per 1 lakh woman years. And still India and African countries, South American countries are suffering from this issue, and we need to work on that. So HPV is the most important factor which we come across of causing cervical cancer. There are patients which are young nowadays. I find even after 2 or 3 children, they get cervical cancer. It could be because of early marriage, because of early sexual activity, because of having more children, multiple sexual partners, and history of previous sexually transmitted infection, which is also an important cause for all this issue of cervical cancer. Immunosuppression also occurs in HIV patient, and that also can cause cervical cancer. And we have got non-HPV related, that is low socioeconomic patients living in juggi jhopadis and slums, patients who have taken a long level of oral contraceptive for a long time, cigarette smoking, tobacco, genetics, and there are autoimmune disorders and other factors which are also there, a part of it. But the progression of the disease over a period of time is weeks to months to years to decades. So it's not happening suddenly. It takes time. There is infection, then there is further viral replication which occurs, and then over a period of time, there is a DNA integration occurring into the tumor cell, and then we have about 0.8% of developing cervical cancer. So it's basically an oncogenic HPV infection. It is a persistence of the HPV infection progression, and then the development of carcinoma and invasion. Well, we are all aware what are the symptoms, but I will briefly go through it for the knowledge of any postgraduates who have joined, and of course the consultants. We have patients who come on and off having bleeding, and we take them for granted as menorrhagia or metropathic hemorrhagica, or they have history of bleeding following an intercourse. So these are the signs you need to pick up, or any abnormal vaginal reddish color discharge. And when you put a speculum inside and you do, the red looking cervix is seen, it is hypertrophied. It's not necessarily that you need to have a cauliflower growth, because that's an advanced stage. It's more than 4 millimeters involvement. But these are the things which you have to take into consideration, and especially those women who are menopausal. We find so many patients also still coming now that they come post-menopausal with bleeding PV, and they are not cervical cancer. It could be a uterine pathology. So you have to think that also in the mind when we are dealing with them. And a further simple pelvic examination, if you put your fingers inside and do a gentle bimanual examination, you will find that the cervix is hard. It is not soft. In an old woman or in a woman who is postmenopausal, in a young woman also it will be hard. It will be firm in consistency. And then it's a clinical staging which takes place, and then a per-rectal examination to further classify into FIGO stage 1, 2, 3, 4, etc. So that you need to understand, and always do a per-rectal examination. It's always important. Do a pap smear, do a HPV DNA testing, and then you have further assistance of the other modalities for diagnostic purpose. But in advanced cervical cancer, you put a speculum, you find a fungating mass, you find a mass which is bleeding on touch, and that's what proves it. And when you do a gentle per vaginal examination, you find that there is a lateral involvement of that spread of cervical cancer into the parametrium, and they also go into the pelvic wall, and that confirms your diagnosis that it has gone beyond the cervix. It has even gone up to the vagina or beyond the upper 1/3 or into the lower 1/3, and you have to do further per rectal examination to see, gentle per rectal examination to see whether there is any rectal involvement or there is any bleeding per rectum, and that will also you will come to know whether the rectum is involved. If there is a hematuria, if there is a painful micturition or a blood in the urine, that also further tells that yes, it is an advanced cervical cancer. And of course, there's backache with such patients. So all these modalities, when comes together, you need to further prove your diagnosis. Apart from the examination of the local and the bimanual and the per rectal examination, you also need to do on a pulse speculum and all the screening tests which you have done. You need to do all these other tests. Examine the lymph nodes, examine the inguinofemoral lymph nodes, see whether she has got any edema feet. Also further, she will have to undergo routine testing, etc. And a small procedure, a colposcopic directed biopsy, a VIA, villi, acetone, acetic acid to be put, and then further biopsy or a 4-quadrant biopsy or a conization, and then a gentle cervical canal curettage, and further diagnosis can be established. So now let's come to the FIGO staging. There is a 2009 FIGO classification, and there is 2018 FIGO definition, which is there. The only change is that now from 7 millimeters, it has come down to 5 millimeters. That's confined to the cervix, and less than 3 millimeters. And then we have one stage. Further, we have 1B, where there is depth is more than 5 millimeters. So that's what, and if it is 1B1, 1B2, 1B3, it will be the maximum diameter should be equal to or less than 2 centimeter, and 1B2 if it is from 2 centimeter to less than 4 centimeter and more than 4 centimeter diameter. Now in stage 2, it remains the same to a certain extent. All the things are same, but in the stage 3, now we have the involvement of the pelvic and the para-aortic lymph nodes, apart from the involvement in 3A, that is the lower vagina, pelvic side walls, ureter and lymph nodes. And then stage 4, this further distant metastasis which occurs. There is an involvement of the rectum, the bladder, and the distant organs where it has gone to 4B. So this is what is the general idea. So basically, in short, if it is confined to the cervix, it is stage 1. If it is gone beyond the uterus, but it doesn't involve the lower 1/3 of the vagina or the pelvic side walls, well, you can still consider to do a surgical treatment to certain extent up to stage 2A, but not involving the vagina as far as possible, because they have found out that the studies, if you do radio chemotherapy and that of surgical, the end result, the survival rate is not going to be that much of a difference. And then if it is gone beyond 3 and 4, well, surgical treatment is out of question. It is going to increase the morbidity and the mortality of the patient. It's no point giving a patient those horrifying surgeries with where she's totally bedridden with exentration being done. So we usually do not reduce the quality of life of such patients. This is another TNM classification which is considered where the primary tumor cannot be assessed. TX, TO, that is no evidence of primary tumor. Carcinoma in situ, it is TIS, then 1 as per the stage 1, then further classified into 1A, 1A1, 1A2, and then we have stage 2 tumor 2, T2, then T3, and then nodes involvement. Similarly, also the distant metastasis where there is, so as along with this, it is similar to that of FIGO staging, and that's what we can then correlate accordingly. So this picture is very clear. It tells us the only involvement where the cervix look normal, there is nothing. Early stage, red looking, bleeds on touch, a small whitish area can be seen, and that is at the external os, and further it spreads where it has gone from stage 1A, 1 to 1B, and then it goes into the parametrium, and then further into the upper 1/3 of the vagina and lower a third of the vagina, then the bladder and the rectum, and so on and so forth. So this is the most interesting part. I ask my postgraduate students who is Ian Donald, they can't answer. I ask them who is John Clark, they can't answer. I ask them who is the father of gynae oncology, they can't answer. So it's very important. Tomorrow we will not be here. Dr. Nirja, myself, others will not be here. I don't know how many people will remember us. Probably our webinars will be archived, and then some people might go through them over a period of time. But that's very important. You need to know who were the pioneers in that aspect to deal with cervical cancer. And this is the picture, what you see of that guy from Austria, Vienna. His name is Ernst Werdheim, on whose name the Werdheim's radical hysterectomy is named. He was the first person, who developed this system in 1898. And in 1905, he reported the outcome of 270 patients, and thereafter he published more number of cases further. But the rate of mortality was 18%, and it was going with a major morbidity rate of 31%, very high. He was ridiculed in the beginning, but somehow it was totally justified by his way of speaking, the way he was explaining and doing the surgeries. And then finally, after a research of more than 14 years, he properly journaled a paper of 500 operations, and that's how his name came into existence as Ernst Werdheim's hysterectomy. The most another important guy is this obstetrician and a gynecologist from USA, from Massachusetts, is Joy Meeks. We commonly know him because of his Meeks syndrome in ovarian tumors. And he is also one of the grandson of Captain Joy Vincent Meeks, who invented an experimental steam monorail. Now we have got metro rails, many of them. In Mumbai, we have got 11 metro rails. Delhi has already gone, earlier, 10 years, 12 years back only they had metro rails. So being the capital city, and then there are now all the things are coming up. So India is developing over a period of time. And in 1944, last century, he repopularized, this Meigs Werdheim's hysterectomy. That is a Meigs hysterectomy, radical hysterectomy. And then the reported survival rate was very good, 75% of patients with stage 1 disease. And the operative mortality rate was only 1%. So probably because of the antiseptics, proper, all the efforts which were taken with antibiotics, and all the importance of survival rate was there. So once you have such a patient, you have diagnosed it, and you have other modalities which you take into consideration, like colposcopy, MRI, or to find out the lymph node involvement. You have worked up the patient, you admit this patient, you take a proper consent. You need to do a pre-op investigation, which includes a routine investigations, because you don't want these patients are sometimes they are anemic. So you need to have proper anemia evaluation prior to surgery, urine to rule out any urinary infection, liver function. It's very important to find out, and also an ultrasound of the liver or further CT to be done. Creatinine and BUN levels are very important because of all the drugs which will be given. A chest X-ray to rule out lung metastasis. You don't need to do an IVP nowadays, but of course the CT will decide upon a lymph node metastasis, any involvement, and see the ureter, whether once the involvement of the parametrium is there into the ureter, they undergo hydroureter, hydronephrosis, pressure changes, and of course you can do any MRI imaging which can detect as 2 millimeters involvement of extra cervical invasion or a lymph node metastasis by a PET scan. So following all these things, you need to stage the patient, and if it is stage 1 to 2A cervical cancer, yes, you can do a surgical consideration. It should be an operable growth. It has not got beyond the pelvic wall, or it has not caused any fixicity. Give her a course of antibiotic, and for 7 days keep her in ward, and then see again, re-examine her. And they don't have any distant metastasis. They should not have, she should be fit. So I have operated even on a Werdheim's who was 85-year-old. My first operation was there with Dr. P.K. Shah. It was a 96, 97. And we have done together probably 75 to 80 Vardaims by now. And of course, sir has retired now from say GS Medical College. Previously, he was at Sion Hospital, and it was a great learning experience. And that's how made me to go into this field of surgical operation for cervical cancer. So it's very important that the patient should be fit. The BUN, creatinine, LFT, mobilization of the patient is very important. Your surgery should be bloodless, and that is the most important thing. And some of these patients might have to, have recurrence. I've seen many patients also, not many, I can say, but few of them, at least 4 or 5 out of 75, 80, have come back with recurrence of metastasis into the vault post-operatively. So it's very important that you need to also take a onco reference also for radiation therapy and try to find out what the best option can be given. And if a patient is very young, then of course ovarian preservation should be considered. But of course, you have to explain her the details. And of course, there is a woman with pelvic masses, pelvic infection, chronic salpingitis, and other pathologies which are there, you have to rule out. So now we come to the classification. There are type 1, type 2, type 3, type 4, and there are different names which are being given. They're all named after the Vardaims mix, and you have a combination of the surgeries. But the simplest one is type 1, which is a simple hysterectomy, extrafacial. Just do a removal of the uterus and the cervix, and you remove the ovaries and the fallopian tubes. And just you don't have to do further dissection into the retroperitoneal space, or take away the ureter away, so that you can do much more laterally application of the clamps as you proceed to do a radical hysterectomy, where you need to go up till the utero-vesical junction and separate the ureter more laterally towards the pelvic wall, and then you go on applying the clamps more laterally. Similarly, the uterosacrals, the rectovaginal space needs to be separated out. So that's the modified radical hysterectomy, and you take as low as possible the vagina. So you totally remove the whole parametrium as much as possible laterally, and go down so that you remove at least 2/3 or at least half of the vagina. And then you have the type 3 mixed Vardheim hysterectomy, where there is a modification which that, and then extended, which is type 4 versus where you have the bladder involvement or the rectal involvement and the exentration which needs to come. So as I said, I briefly described you also simple hysterectomy, which tells you, but you do not require the excision of parametrium and paracolpus. Just leave it alone. It is very good for stage 1A cervical cancer and patients who follow up with you. It's very important. Modified radical hysterectomy, where you remove the cervix, the proximal vagina, parametrium, paracervical tissue. And this hysterectomy is well suited for tumors up to 3 to 5 millimeters depth of invasion and smaller stage 1B tumors. Radical hysterectomy type 3 Vardheim mix, you require a greater resection of the parametrium, extending up till the pelvic lateral wall, and you have at least 2 to 3 centimeters. So more of the proximal vagina you take, and the procedure is performed even for larger 1B lesions. Extended, as I said, here you need to remove the periuretral tissue, superior vesical artery also dissection, and 66% of the vagina. And it's usually when to be done when there is anteriorly central recurrence, where preservation of bladder is still possible. And the last scenario is exentration, where you have to remove a portion of the ureter, a portion of the bladder where it is dissected, and you have to again do all the anastomosis to be done, and a multidisciplinary approach has to be done. So usually in such cases, we have to be very sure that the patient is under control of diabetes, hypertension. She doesn't have any other pathology. She needs to be taking a proper medical reference, a surgical standby if you need, and a proper, pre-operative anesthetic fitness evaluation has to be done. Blood grouping, cross-matching, at least 4 bottles of blood should be arranged. And you need to give a heparin at least 8 to 24 hours prior to surgery. Stocking should be kept ready, the leg stocking. Bowel preparation is very important. You need to give her 2 times enema, then high bowel wash, keep her NBM for 2 days with an IV line so that she doesn't get dehydrated. her renal function test, liver function test, and her all the parameters are well monitored, and then she's taken free on the OT table. So in short, you have a very simple chart here, which will tell you that if you have a patient which is less than 3 millimeter with stage 1A1, just do a type 1 hysterectomy and get out of it. But if it is 3 millimeters invasion and there is LVSI, then you need to do radical hysterectomy or a type 2. And 1A2, 1B1, you need to do a radical hysterectomy or a type 2 radical hysterectomy with pelvic lymphadenectomy. So pelvic lymphadenectomy is the most important thing, and it has to be done bilaterally. It has to be done properly. You also need to put a drain inside retroperitoneally, post-operatively, and the incision has to be taken appropriately. I will come to that. So this is what is stage 1, where you need to do a radical hysterectomy, except for less than 3 millimeters invasion. You can do a type 1 hysterectomy and come out. If it is 1B2 and stage 2A, then there is type 3 radical hysterectomy, as I already explained to you, with pelvic and para-aortic lymphadenectomy, which is also important. And then she needs to undergo radiation. So you have to decide accordingly whether it is radio sensitive, radio resistance, whether it is adenocarcinoma or whether it is squamous cell carcinoma. And of course, if it is 2B onwards, she will go directly to radiotherapy. No need to undergo all this extension and further morbid surgery to be avoided as far as possible. There is something like micro-invasive 1A1, 1A2 disease. This is also cold knife conization, simple hysterectomy, and all these things also can be done into consideration. And stage 1B, 2A, cervical cancer, where there is an invasive early, it can also undergo a surgery or a radiation therapy. And then if you undergo a surgery, you need to do a radical hysterectomy with bilateral salpingo-oophorectomy, and a pelvic lymph node dissection is a must, or she directly goes to radiotherapy. There is something like loco-regionally advanced cervical squamous cell carcinoma, where primary radiotherapy is the best treatment of choice as per the NCCN guidelines. And they suggest either a radical hysterectomy or initial chemoradiotherapy in this setting. Stage 4B, you have recurrence. A patient comes back again following a radical hysterectomy or a definitive chemoradiotherapy for an early stage. And if the recurrence is a local, the same holds true for adenocarcinoma, then she will have to undergo a surgery, which can be an extenterative one, which an option will have to be given to such patients as if they have centrally relapsed disease. Surgical resection may be useful in metastatic diseases, and you have to select the proper patient so that the morbidity is reduced. Probably, unfortunately, they have an isolated pulmonary metastasis. Well, this surgery can go for more than 3.5 to 4 hours, and it's always better that it is done by yourself if you are in a private setup or in a tertiary center or in a medical college with a senior around you, and it's always better. I prefer to do a ureteric catheterization, which will help me that I do not injure the ureter, and the ureter is away when I'm doing a radical surgery. But there are two schools of thought. Some of them do not put the ureter. They just go ahead and perform the surgery, and that is the choice of the surgeon or the gynae-oncologist who wants to do. You have to do a proper examination, a proper evaluation, and then go ahead. But remember, there are going to be complications. Blood loss is a major issue, and post-operatively, she needs to be corrected with her anemia. And we have patients also coming up with worse situation where there are fistula occurrences, VVF, or a ureterovaginal fistula. So that can be detected immediately when you are doing, or unfortunately, if it is missed out, then you have to, you will be seeing it later on in an ultrasound or a CT to be done later. Patients can have thromboembolism, so mobilization is very important, and that could be pulmonary one. There could be also 1 or 2 or 3 days a patient goes in paralytic ileus, and unfortunately 1% of them can go in small bowel obstruction. So you need to have to understand. And post-operatively also, you need to importantly see the urine routine microscopy, the urine culture, so that she doesn't have urinary tract infection or a respiratory tract infection. And the worst scenario also I have seen is a burst abdomen in a vertical midline incision, which has been taken post-operatively on day 7. So your surgical technique, suturing of the, the abdominal wall layers up till the skin has to be done by yourself, preferably. Do not give it to a junior one. And a proper, management of wound dressing is very important. Doing a Verdheim's hysterectomy is not so, it might be the easiest or a cakewalk, but post-operative management of such cases, coming out of that surgery, walking back home with a good survival rate is the most happiest moment you can give to the patient, and you feel good about it that you have done a wonderful job. And of course, there is damage to the adjacent organs. Be careful when you are doing cauterizing or cutting any tissue. Have some tissue sense. I always say to my residents and doctors that there is something like, apart from 6 senses, which we have the 6th sense, there is tissue sense. Be gentle, be considerate towards the tissue. Don't do some Narsima techniques and don't be rash. And your whole pool of blood is there in the operative field that totally demoralizes the assistants, and they are just going to go haywire. You should be in the control of surgery. You should guide your assistants to do them properly, to assist you. And I always say the best surgeon is the one who is a good assistant. So first learn to assist and then go to become a good gynae oncology surgeon. There are some patients which will require fertility preservation. You need to counsel them, talk to them, and they will also go a simple trachelectomy or a simple, radical or a cervical conization. But they need to be explained. Their ovaries, ovarian embryo, the fertilized embryo or the ova after ovulation treatment needs to be taken, and then that can be done. Subacute complications are also seen quite commonly. There are bladder dysfunction. The patient is with a bladder catheter for 7 days. I remember in those days, 30 years back, we used to keep patients catheterized for 21 days. Then it came to 14 days. Then it has come to 7 days now. So if you keep prolonged, then the patient needs to undergo bladder training. And then worst to worst, ureteric fistula or a urine retention, a hot water bag, and trying to educate her, clamping the catheter, Foley's catheter, and then releasing the clamp every 5 hours, 4 hours, and then gradually she's trained with the bladder. That is very important. Lymphocyst formation is also one of the complications. So you need to put a proper drain in the retroperitoneal space. One drain will be in the paracolic gutters, and the other one should be in the retropelvic area where you have done a lymphadenectomy, because that the lymph gets collected and that comes off on, and that also should not cause any lymphocyst formation. And a proper good antibiotic coverage and a good ambulation, thromboprophylaxis, mobilization, bladder training, confidence should be given to the patient. In spite of all these things, a patient can land up with bladder hypotonia, bladder atony, and the ureteric stricture, which is very rare, but you have to go through this whole things. Now we come to something like neoadjuvant chemotherapy, where we also have seen in the ovarian cancer, and this can also be given rather adjuvant therapy after hysterectomy, and it's especially helpful in cervical squamous cell carcinoma, where you have the histopathology. With the report comes, there are positive of closed resection margin, lymph nodes are positive. She needs to undergo this therapy, and there is also, or there is a microscopic parametrial involvement. This is the neoadjuvant chemotherapy, which is a chemosensitive neoplasm. Cisplatinum-based regime are also used. I have never used. I have sent them for radiotherapy, but this is not my experience. Adenocarcinoma are similarly chemotherapy sensitive, and at least in some settings of advanced disease. And the use of neoadjuvant chemotherapy may be beneficial in selected patients, but whether this strategy provides any superior outcomes over chemoradiotherapy is unknown, but I have not used. Well, after this, then we come to palliative therapy, part of it, which we have already covered. Pain is a very important management, and the patient needs good counseling, good pain relief, medications. She needs analgesic, a good nursing care, and a good psychological, physical support with a good follow-up. And I'll tell you, the patient will come out very, great. This is what, to avoid all this things. You need to have prevention and control of cervical cancer. That's what Foxians and we all are doing. We have primary prevention, secondary prevention. This is what already been discussed in the panel discussion and also been talked by Dr. Nirja, madam. And now we are talking about something like tertiary prevention. That's my forte, where I'll end up with an surgery or an ablative surgery or a radiotherapy or a chemotherapy, but a multidisciplinary approach needs to be done in such cases. And this is to reduce the number of mortality due to cervical cancer. Now, unfortunately, there are patients with pregnancy, they'll end up with cervical cancer. In my 30 years now, I have only seen one case. Maybe the oncology department or any other gynae oncology center might have seen much more, but I have only seen one of such cases. And one half of these cases are diagnosed prenatally and the other half are diagnosed in 12 months after delivery. Well, it is supposed to be said to be a common malignancy in pregnancy, and the estimated rate is very less, but it is 0.8 to 1.5 in 1 lakh women. Now, unfortunately, you have such a patient with cervical cancer in pregnancy and the fetus is not viable. You have to continue with the routine management of cervical cancer, or she is diagnosed after delivery within 3 months, then do the routine management of cervical cancer. You come on to the left arm on the left side. If the fetus is viable, it will depend at what period of gestation. So if it is more than 30 weeks, fully developed, and it is fine, you deliver her when the fetal maturity comes, and then you manage her with postpartum management of cervical cancer. But if she is in less than 20 weeks or in between the first and second trimester, you need to do a repeat cytology or a colposcopy after 12 weeks during the pregnancy. And if it is negative, continue the routine screening. If it is positive, the routine management of CIN or cervical cancer needs to be done. This is my book, which I have written along with Dr. Sachin Ajmera. You can go through it. It's available at Bharani Medical Store or on Amazon. And it's a very helpful book for all the postgraduate students and even consultant. It is a reference book. So if you need to be a good surgeon, you should remember 3 S and 1 R: safe, sure, and swift. You should be safe, sure, and swift when you perform a surgery. And R, continue doing relentlessly the surgery. My mom tells us, me, when I was a medical student, your eyes should be like a hawk eyes, eagle's eyes. Your fingers should be lady fingers. You should have a lion's heart, and continue doing your surgery so as to give the best to the patient and help in reducing the incidence of cervical cancer and reduce the morbidity and mortality in our patients. Thank you so much for a patient hearing.
Thank you very much for a very informative talk. You started from the history, symptomatology, and build up your lecture to the treatment and then palliative care and even the post-operative complications. And the best part of all the history, which nobody nowadays, really paid tribute to the persons who have discovered these great operations. I think 2 more scientists which I can add is Shota's operation and Mitra's. And we have to really remember those and keep inventing or keep discovering new things. Very informative talk. And
Madam, I apologize for not taking their name, but they have also created a name in the history. And kindly forgive me because
no, it's not that question. Just I remember them.
No, you have corrected me, and I really appreciate that. It's already mentioned in my book, but I have seen Dr. Saraugi sir doing a vaginal operation.
He's a good surgeon.
And I have heard when I just joined residency in 91, there was one Dr. Shanbag. He used to do the vaginal operation and of course Mitras. I never seen them, but I've seen a video of them. So all these surgeries are there, especially in SUI and cervical cancer.
Interesting, yeah.
Interesting, and it's a field which I decided that apart from doing infertility or doing only endoscopic surgery, this is a very important topic where our country needs a lot of our Foxians and a lot of our members to contribute. Just going into the glamour of infertility, IVF, fertility, or just doing, or showcasing some pieces of meat dangling down with a endoscopy. I'm not criticizing anyone.
Yes.
I'm also part of this whole thing.
Actually, you are from medical college. We have to do everything from obstetrics to oncology. So we can't just do one thing at a
Yes,
time.
madam. So it's very important. I mean, I've seen so many of my students who are very good surgeons, who are very good, clinical acumen. Maybe Dr. Neerja also will agree. And I find them after 5 years, they are IVF consultants. They are just doing something which they could have done much more. So I think those surgical skills, Indians, we are very good surgeons. If you go
Yes.
abroad, madam, you can see Dr. C.N. Purandare sir or Shirodkar sir, or even Dr. I'm not just talking about any professor. There are so many of us, who have devised so many surgical skills, because we have got those patients. We have got that much, so many patient turnover, which others don't have.
And that new formula, triple SNR, we'll never forget. Very nice. Very nice.
So thank you, madam. Thank you, Dr. Monica and Neerja, madam. It was so nice. Anita ji, I see your flowers in Fox D, and of course, Madam SP Jaiswar, madam. I have seen you and met you in person.
Wonderful talk, Dr. Chauhan. I was just listening it. I also remember we have read Chautas, Mitras only on book, although you may have seen it also, but really, these are the people who are really, they worked a lot. And as being in a medical college, we have to do all the things, because whatever the patient comes, the patient herself teaches us.
Yes.
So many times we learn from our own patient. We have to change the technique also of the surgery, just depending upon the need. So definitely.
I want to tell you one more thing, madam. Last 3 years, I have not done a single Vardimes. Can you believe? Why?
You don't get patient. Either they come
also feel sad. Definitely, ma'am.
Because the whole credit goes to the robust system of
MRI.
Early cancer
MRI.
detection, awareness. The early
Not
cancer
awareness,
detection,
ma'am.
screening.
Nahin, sir, Doctor Sahab, the MRI shows the one lymph nodes is enlarged. It has good so 3C. Now it is not operable. That is the problem. Otherwise, I used to do Vardaim in every OT. But now, every OT one.
The incidence has gone down because patients' awareness has improved.
Both things are there. Yeah.
There are so many things involved, and I really appreciate the efforts done by all of us. I mean, really. Now they are the students. Sir, please, हमको एक Vardimes बता दो. मैं बोला कहाँ से बताऊँ? Either they have gone advanced, 1/3 of them, and most of them are early detected, because lot of hammering has been occurred because of HPV infection, screening, see and treat, and that's really great.
We were dependent on the clinical only, na? We did not have so many tools, imaging tools. So clinically, it is pharmacies are free. Let's go for the Vardimes. Now it is not. You have to follow according to rule.
But ovarian tumors are still the same. Ovarian tumors are still the same. Adolescent girls, they are still the same. Yeah, it is not stopping at all. And I see more and more cancer apart from benign and so many things. Peritonectomy has changed the whole thing. Peritonectomy, along with removal of the ovarian tumor mass and the other ovary, depending upon what is the situation and the age and etc., it has made a lot of difference. And the chemotherapy, the drugs have really worked wonders, and that's what the survival rate, the prognosis is good. So thank you so much, ma'am.
Thank you. And I thank the organizers for giving us the opportunity. Thank you.
Thank you, Neerja.
Thank you, ma'am. Thank you, Chauhan sir. Thank you, Amita ma'am.
Thank you very much. It was very nice, very educating. Thank
Yes,
you.
so
Bye-bye.
Monica, Dr. Monica.
Yes, Anita.
Thank you, Dr. Monica.
Anita,
you were very good.
Yes,
Thank you so much.
Monica has taken a lot of efforts.
Lot of
Right.
pains. Thank
So
you,
now
Dr. Monica.
it's my pleasant duty to deliver my vote of thanks and acknowledge the hard work of all the great people over here.
Yes,
so
madam.
first of all, I start with, our president, the main leader, visionary leader, Dr. Pai, and of course, our Secretary General, Dr. Madhuri, and of course, our Dr. Alka Pandey, ma'am, who's the Vice President in charge of our Public Awareness Committee.
and our very, very bright chairperson, Dr. Priyanku. He couldn't make it. He is still hardworking. He's doing the cesarean, emergency cesarean. And of course, our Dr. Kalyan, who was a past chairperson. And along with that, it was really a star-studded webinar because we had such great speakers like you, Dr. Niranjan, and our Dr. Nija Batla. She has really made all of us shine everywhere in the world. So because of her, we are known now. And our great moderators for the panels, of course, Dr. Alka Pandey ma'am and Dr. Nisha, and my chairperson, Dr. Jaiswal, and of course, Dr. Amita Suneja now, who is the president of AOGD, who was your chairperson, along with Dr. Vidu, who is also our North Zone coordinator, along with me, and all the great panelists. And also, these coordinators, Dr. Monica and Dr. Shatabdi, who really relentlessly, they've been working hard to manage this whole show. And each one and all our audience, because it's everyone's togetherness. We always say it rocks because everyone's energy, enthusiasm, cooperation, and your leadership, all of you. So you are guiding us from horse's mouth. We are learning. So we'll be able to spread. Ultimately, we want to do it to the community. So we will be able to spread the messages. We will be able to create the awareness and tell them to go for vaccination. And now HPV, we have learned from Dr. Nija, so that we're going to promote. And so ultimately, we're all going to counsel. And what you said was lacking, the monitoring and the follow-up. So we are going to go and do all this work under your guidance. So thank you, all of you, from the bottom of my heart and from our whole team. And of course, the organizers, the Corona people who were right there in the beginning, right at 3:45. And I'm very sorry if I haven't taken anybody's name. So please forgive me because I'm recovering from viral. So I will be forgiven. So thank you so much.
Of course.
Thank you so much.
All the best.
Thank you, ma'am. Thank you, Anita, ma'am. Heartfelt thanks to everyone on behalf of the Public Awareness Committee.
And Dr. Alka Kriplani, ma'am. Dr. Alka Kriplani, ma'am, please. Yes. Our chief guest, I forgot. And because Dr. Archana had to come. And today, I think AIMS was overshining. Dr. Alka is my most favorite person. And she's the one who actually inspires us. And we always get motivated by whatever little word also she says. So that's why I said I'm recovering, so she will forgive me. So Dr. Alka Kriplani, सबसे पहले उन्हीं को बोलना था. Thanks. So yes. Thank you so much. Yeah. Okay, Dr. Monica, over to you. Thank you so much.
Thank you so much, ma'am. Thank you, Niranjan sir, and thank you, Nija ma'am, for joining in spite of your busy schedule. Thank you so much. Yeah. I would like to tell you that we have had an attendance of 522 delegates across the world.
Great. So today Delhi was also very prominent. Dr. Mamta Dagar also. She
very wonderful. Well
Thank
done.
you.
Well
Thank you so
advertised.
much, Doctor.
Whole day.
Yeah.
Okay. Bye. Good night.
Good night, ma'am.
Bye. Have a great day and great days ahead. Bye.
Thank you.
Bye.
Thank you, ma'am.